Hello, hello. ये मेरा phone है. It's okay. Good morning, everyone. Welcome to the morning session of Epicon 2021-2022. We are going to start with the free poster presentation. We have with us Dr. Varun Malhotra as the judge. He is Associate Professor AIMS Bhopal. He is a teacher and researcher with passion, and his main topic of interest is mind, body, medicine, and yoga. For the first presentation, I would invite Dr. Swapnil Parlikar, Associate Professor from Government Medical College, Bhavnagar. Dr. Swapnil?
Yes, madam.
Okay. Can you please start? The topic of presentation for Dr. Swapnil is acquisition of higher order cognitive skills using the flipped classroom, a quasi-experimental study. The time for poster presentation will be 8 plus 2 minutes. 8 minutes for the presentation and 2 minutes for the question answer session. You can please start.
Yes. Good morning to the respected judges. It is indeed a privilege to be presenting a free paper in the annual conference of the APPI. I am Dr. Swapnil from Government Medical College, Bhavnagar. We know that in a traditional sense, the lecture is taken first and this is followed by homework activities. While in the flipped classroom, the lecture and homework elements of the course are reversed. So the student watches online videos or studies standard textbooks, and the in-class session, which is the soul of the flipped classroom, is used for active learning, like small group discussion. It is believed that knowledge and understanding are developed during the pre-class session, while higher levels of the cognitive domain like application, analysis, synthesis, and evaluation are attained during the in-class and post-class sessions. There is a recent meta-analysis which has demonstrated that there are definite learning gains with the flipped classroom and students like the flipped classroom approach. But evidence regarding Hawks or higher order cognitive skills like application, analysis, evaluation, and synthesis is scanty, and there is one paper in Journal of Chemistry Education regarding this. So the aim of our study was to compare the flipped classroom with the traditional didactic lecture. The objectives were to compare the learning gains by both the methods and to determine whether the flipped classroom is superior to the traditional lecture for acquiring higher order cognitive skills and to ascertain the perception of the students regarding the flipped classroom. The study was quasi-experimental in design. There was an intervention, but the students were divided randomly based on their roll numbers. It was conducted in the Department of Physiology at Government Medical College, Bhavnagar. Phase 1 MBBS students of the batch 2021 during the COVID epoch, and prior approval of the ethics committee was taken. Written informed consent from all the participants was taken. Out of 200 students, 102 students completed all the phases of the study, right from giving the informed consent to the pre-class test and to the attending both the modules of the flipped and the traditional lecture and the post-class test and the feedback questionnaire. 2 topics were selected based on optimum difficulty level that would enable the students to attain the higher levels of the cognitive domain like application and analysis, and on feasibility aspect. Topic 1, cardiac output. Topic 2, regulation of blood pressure. Specific learning objectives are the 2 topics were prepared. 6 videos were prepared by the principal investigator, 8 to 10 minutes in length. This time is considered Goldilocks for the attention span. Multiple choice questions with clinical vignettes were prepared based on the Blooming Biology tool. This tool provides a template as to how the items for assessing each level of the Bloom's taxonomy needs to be constructed. The SLOs, videos, and MCQs were validated by 2 external physiology faculty from Gujarat, one from NHL and other from AIMS Rajkot. The feedback questionnaire was validated. It was based on Paul Ramsden's course experience questionnaire and big study process questionnaire. Though in our setting, internal consistency, that is the Cronbach's alpha, was calculated and it was found to be satisfactory, 0.874. The following are the themes of the feedback questionnaire. Two separate WhatsApp groups were created for sharing the videos. A Google Drive link was created for sharing the videos 4 to 5 days before the class. Now, this is the central slide, the chronology of the flipped classroom. The pre-class test and sharing of learning objectives was in both the groups, while the flipped classroom group watched the pre-recorded videos which were shared in the WhatsApp group. They read standard textbooks, the learning objectives serving as a guide for reading the standard textbooks. During the class session, an ERAT, that is Individual Readiness Assurance Test, was conducted, but there was no culling of the participants based on the ERAT marks. Discussion in groups of 6 to 8 on questions relating to the topic were conducted. The probes were, that is, athletes have bradycardia or traffic policemen standing in long time for a long time in hot weather are prone to fainting attacks. Eliciting of responses from the groups with clarification by the facilitators to investigators and to residents, and finally summarizing by the facilitator. In the didactic lecture, there was a lecture, 60-minute lecture, followed by 15 minutes of solving queries. And 1 week later, the post-class test was conducted. The feedback questionnaire was administered immediately after the flipped classroom. So this is the distribution of topics. Topic 1 was taught to group A by the flipped classroom and to group B by the traditional lecture. And topic 2 was taught to group A by the traditional lecture and to group B by the flipped classroom. The students generally gave a positive response, and there was no difference between the responses in both the flipped classrooms, indicated by a small effect size, that is R is less than 0.3. Now, coming to the discussion, the flipped classroom embraces the constructivist paradigm. The pre-class session, the students gain knowledge and understanding. It is just like laying the bricks of a brick wall. But during the in-class session, new cognitive schema are formed, and this helps in strengthening the bricks by laying mortar. The teacher, rather than a sage on the stage, is a guide on the side, always there to present and provide feedback. And as we know, according to Professor John Hattie, feedback has one of the strongest effect sizes of any learning intervention. It personalizes the learning experience, facilitating just in time, just for you, and just the right place learning. The flipped classroom speaks the language of today's students who are accustomed to the web and social media for learning. The strength was that it assessed higher order cognitive skills rather than being a simple comparison of knowledge and understanding of the two models, while ethical considerations mandated that the marks obtained in the post-test may not be considered for internal assessment. Hence, both the investigators, senior investigators, felt that the motivation of the students may be suboptimal. Future directions: assessing the attainment of creativity through the making of concept maps, which will be graded according to Novak's criteria, and developing, depending on the feasibility, of flipped mastery classroom. These are my references, and this was part of my advanced course in medical education at PSMC Karamsad. So I thank the faculty at PSMC Karamsad profusely. I'll sum up with Aaron Sand's words that flipping a classroom is more about a mindset, redirecting attention away from the teacher and putting the attention on the learner and learning. Thank you and have a good day. Any questions?
Any questions are there online from the online participants?
Dr. Swapnil Paralikar?
Yes.
I have a question.
Yes, sir.
You had mentioned that the research was done during 2021 during the pandemic, right?
Yes, sir.
So the question is that you had designed the Flipkart model of some activities. How were the activities assessed, or what were the activities, say cardiac output and regulation of BP? And did the students, because it was in the online mode during the...
No, it was not in the online mode, sir. After the of course, this batch is, we consider the COVID batch, but it was after the acute in April, May, it got over. Then we did in June, July. Then the students had come to our college. So it was physical.
Okay. Thank you for that. Just wanted to check out the honesty of the study. So you found basically the Flipkart model better. because you were able to assess the higher cognitive skills, right?
Yes, sir. It was slightly better, though we expected better marks from the students. But I think the motivation, because of the COVID and these marks being not considered for internal assessment, the motivation was less. Otherwise, I would have expected marks to be around 7, 8 after the flipped classroom.
Right, thank you. That explains why the motivational and the reward punishment centers model should be also applied for assessing, right? Thank you so much, Dr. Parag.
Thank you, sir. I'll take it into
Thank,
consideration.
thank you, Dr. Swapnil. Our next presenter will be Dr. Vinitha K. Ramdas Nayak, who is Associate Professor at Sri Gokulam Medical College, Kerala. The topic of her presentation is Body Adiposity Index as a screening tool for identification of prediabetes. I'll repeat, the time will be 8 plus 2 minutes, 8 minutes for the presentation and 2 minutes for the question answers. Dr. Vinitha, you can start. Okay. You can start. We cannot hear you.
Good morning. Am I audible?
Yes, yes.
Okay. Is my screen seen?
Now it is,
Okay.
yes.
Yes. Thank you. Okay. Sorry for the trouble. Yeah. So my topic for oral presentation for today goes on body adiposity index as a screening tool for identification of prediabetes. So as we know, prediabetes is an evolutionary state of type 2 DM where the subjects have metabolic dysfunction and they share the manifestation of hyperglycemia. According to the study done by ICMR India DAY, 7.3% of population in India has diabetes, and the prevalence of pre-diabetes is higher, as much as 24.7%. So hence it necessitates us to find more mass screening tools to identify pre-diabetes at an early stage. So according to the previous studies done, traditional anthropometric indices like waist circumference and BMI fail to distinguish visceral adiposity, which is considered as the major contributing factor, from subcutaneous adiposity in identification of prediabetes. But the gold standard MRI and CT, which are accurate in measuring visceral obesity, are inappropriate because of their time-consuming nature, cost, and requirement of skilled manpower. So hence, it necessitates the requirement of finding easily doable anthropometric indices which are more accurate. So one such was novel anthropometric index was found by Bergman in 2012, known as body adiposity index. There's no necessity of measuring weight in it, which makes it more adaptable for doing mass screening. Only hips and hip circumference and height. So it's hips and hip circumference in centimeters divided by height in meters minus 18. This is how it is derived. So objectives were to assess the efficacy of BAI, body adiposity index, to screen pre-diabetes in South Indian population. The study was conducted at KMC Manipal in the year 2019 to 20. In subjects aged 30 to 55 years who attended the master health checkup in the Department of General Medicine in collaboration with the Department of Physiology. It was a case control study. We actually took 83 cases and 83 controls. The ones who were qualified to be pre-diabetes had to come under the American diagnostic criteria, that either they had impaired fasting glucose between 100 to 125 mg per deciliter, or impaired glucose tolerance between 140 to 199, or HbA1c between 5.7 to 6.4. Controls were comprised of other voluntary participants with normoglycemic levels who attended the master health checkup, including the excluding criteria that they didn't have, self-reported hypothyroidism, self-reported cardiac diseases, or they were not on any self-reported medications. Height, weight, waist circumference and hip circumference and other anthropometric measurements were measured according to standardized protocols. And with this help, we did it. We measured body adiposity index in them. For the statistical analysis, we compared the traditional anthropometric indices, that's waist circumference and hip circumference, with and BMI with body adiposity index in using independent t-test, and the sensitivity and specificity of each of these anthropometric index along with area under the curve with 95% confidence interval was done. So the interpretation of RUC was between 0.8 and 0.9 was considered good with good predictable ability, and 0.7 to 0.8 was considered as fair. So the results, you can see that the BMI, with the p-value, it was significant, but for both, this is for both men and women together, you can see that body adiposity index was not significant. But when it comes to diagnostic accuracy of BMI and BI to predict PD in males, we can see that it is the AUC, area under the curve, for waist circumference and BMI was 0.65 and 0.67 respectively. For body adiposity index, it was better than that. And in females also, in body adiposity index performed better than BMI and waist circumference. So the main findings of our study is the results of our study affirmed that body adiposity index was significantly higher compared to healthy controls in both the genders. But this is a part of a larger study in which we have compared the traditional anthropometric indexes, which is waist circumference, hip circumference, and BMI with the novel ones. So when we compared it in our previous study, we found that waist circumference was better predictor of prediabetes in comparison to other body composition parameters such as body fat percentage. In this study, we found out that body adiposity index performed better than waist circumference and BMI also. So our results reconfirmed the reports from previous studies which mentioned that body adiposity index is a sensitive tool to measure obesity, which was done in Caucasian and Mediterranean population. Previous studies indicate significantly higher sensitivity of body adiposity index in estimating body fat in obese people than its specificity in population-based studies. So what is the advantages of body adiposity index? Body adiposity index can be done in mass screening because you need not take a weighing machine, weight is not needed, and it is said to measure body fat percentage more accurately than BMI. So conclusions, the study says that it shows good sensitivity, specificity for estimating body fat in adults with prediabetes. So it can be recommended with as complementary to BMI and prediction of prediabetes, and body adiposity index has a high utility value due to ease of collecting data and ease of calculation. These are my references. Thank you. Yes, sir.
Can you hear me now also?
Yes, sir. Yes, sir.
Okay. See, body adiposity index was a good alternative kind of tool that you selected. Did you kind of analyze the gender differences? You said in both it kind of, because generally the literature says
it is better in females, sir. It's better in females.
Exactly, because the females, the weight distribution is more on the hips, and the males, I think the waist hip circumference is the waist circumference is a better indicator. So did you analyze that aspect because you haven't
Yes,
seen the
sir, we have
gender?
analyzed. So it's better in females. Even the results are better in females.
And for waist circumference, which you were mentioning was your largest study, that did you
In
analyze
the
in females?
larger study, sir, waist circumference, it was between traditional anthropometric measurements and body composition analyzer predictors. In that, waist circumference was better than the rest of them, like body fat percentage and lean mass percentage. So waist circumference was a better predictor. In this study, we found that body adiposity was better even than waist circumference.
And how much would you suggest should be the waist circumference and hip circumference normal based on your normative data that you would suggest for pre-diabetes as a
One second,
marker?
just read up. Here the cutoff value in males is 94.5 and in females is 90.5, which we have got out of our data.
Thank you. And for waist circumference?
That
Like
I
you
told for
suggest.
waist circumference, sir.
This was in 90.5 is in centimeters.
In centimeters, sir.
And for body adiposity index?
25.6 is the optimal cutoff and 28.6 in females.
Right. Thank you so much, sir.
Thank you, sir.
Thank you, Dr. Vinita. Any other questions from the audience?
There was just one more thing since you mentioned. There's another suggestion. Could you correlate these values? Correlation regression would have been a better kind of, along with the circumference, both and BAI in males and females. Did you draw the correlation regression graph?
No, sir, not yet.
That could be something further where you can probably, publish.
Yes, sir. Thank you, sir.
Thank you, Dr. Vinita.
Thank you.
Any other questions? Okay, thank you. So next we have with us Dr. Zoha Khan, who is a postgraduate student at IMS BHU Varanasi. The topic of her presentation is to study the correlation between muscle strength parameters and severity of depression. You'll get 8 plus 2 minutes. Dr. Zoha, you can start. Are you there, Dr. Zoha?
Yes, ma'am. Just give me a moment. I'm sharing my screen.
Okay, sure.
My screen is visible. Is it visible? Hello?
Yeah, your screen is visible. You can start.
A very good morning to all of you present there. In today's presentation, I'm going to present the paper titled To Study the Correlation Between Muscle Strength Parameters and Severity of Depression. Depression is a serious mental health disorder. It not only affects how one feels and thinks, but their daily routine activities as well. It has been seen in recent COVID-19 pandemic and the lockdown that has been implemented. Its impact has increased to many folds. Hand grip strength is an easy and objective measure of overall fitness. And in previous studies, it has been seen that physical fitness and physical performance has a strong correlation with the severity of depression. This has already also been seen in the hand grip strength performance of the subjects. Although hand grip strength is extensively studied for this correlation, other muscle groups are not as much studied for this correlation. For example, force of plantar flexion. So our objective was to assess the correlation between PHQ-9 score of patients with depression and their muscle strength parameters. After getting the ethical clearance from the ethical committee of our institute, patients were recruited from the Department of Psychiatry, IMS BHU, after applying the inclusion and exclusion criteria. Exclusion criteria being any psychotic disorders like schizophrenia or muscular dystrophy or any disease causing muscular weakness or any chronic disease. And inclusion criteria were patients with depression who were attending the ward, attending the OPD or were admitted in ward for treatment. And the age group that was selected was 18 to 60 years. After getting recruited, the patients were asked to give the informed consent and a brief history of their current illness was asked. And then the PHQ-9 score was calculated. Now, PHQ-9 score is a 9-item based module, which includes 9 questions pertaining to 9 symptoms which are diagnostic as defined by the Diagnostic and Statistical Manual of Mental Disorder edition 5. And patients are asked whether they are experiencing these symptoms for last 2 weeks and how frequently they are experiencing these symptoms. And on the basis of the frequency, they are scored from 0 to 3. Ultimately, these scores are added up and their total score is calculated. On the basis of their total score, they are divided into the different severity group, being the minimal or no depression, mild depression, moderate depression, moderately severe depression, and severe depression. For assessment of hand grip strength, we used baseline Smedley digital hand dynamometer with maximum capacity of 90 kg and resolution of 0.1 kilogram. The protocol which was utilized for assessment of hand grip strength was according to the guidelines given by American Society of Hand Therapists for hand grip strength testing. For assessment of the force of plantar flexion, we used a pre-standardized force transducer designed in our laboratory with collaboration of IIT BHU of a measurement range of 0 to 200 kilogram and a precision of 50 gram. Here in this image, you can see this was the force transducer attached with an acquisition box, and one end of it was attached with a ankle cuff. Here you can see the ankle cuff goes in the feet of the patient, in the foot of the patient, and the other end of the force transducer was attached to the seat of the patient. The acquisition box was further then connected with a laptop having a software with help of which we used to assess, get the real-time reading of the force, and also we could ask the subject to perform the sustained contraction, and we could assess the endurance time for it. And this is the image for patient in ward that we took the data from, and this is the image of patient in the laboratory. These are 2 other images of the patients in the laboratory. For statistical analysis, we used the statistical package for social sciences version 22.0, and the normality of data was assessed with the help of test Shapiro-Wilk test. For assessment of the correlation, we used Spearman correlation test, and for comparison of means between 2 groups, we used Mann-Whitney-U, and for between multiple groups, we used Proskal-Wallis test. In our study, we observed that 54% of the patients were female and 46% of them were male, and majority of them were from the age group of 18 to 30 years, that is younger adults. When we compared the baseline characteristic between the male and female patients, we observed that age, PHQ-9 score, and different muscle strength parameters were comparable between both the genders. There was no significant difference. On the basis of the PHQ-9 score, the patients were then divided into different groups, group 1, 2, 3, 4, which corresponded with the PHQ-9 score severity criteria of mild, moderate, moderately severe, and severe respectively. And then muscle strength parameters were compared in between these 4 groups. It was found that maximum force of plantar flexion was significantly correlated, significantly different amongst these severity groups, while other parameters were not that significantly different. On assessing further applying the post hoc analysis, we found that maximal force of plantar flexion was significantly different between group 1 and 2 and group 1 and 4. On assessing the correlation between the muscle strength parameter and the severity scores of these patients, we found that the maximal force of hand grip strength and maximal force of plantar flexion was significantly correlated with the PHQ-9 scores of these patients, the severity of the depression scores of these patients. And the endurance time for force of plantar flexion was significantly correlated with the PHQ-9 scores of these patients, while no such significant correlation was observed for the endurance time of the hand grip strength. Before getting to the conclusion, I would like to summarize the results that we obtained. The muscle strength parameters significantly differ in the different severity groups based on their PHQ-9 scores. Maximal force of hand grip strength and force of plantar flexion show significant correlation with severity of depression. The endurance time of force of plantar flexion shows significant correlation with severity of depression. With our observation, we came to conclusion that muscle strength parameters show correlation with symptoms of depression. This is in sync with previous studies as observed that muscle strength parameters were significantly correlated with the severity scores of different type of questionnaires of depression. And in fact, they have also seen that patients having, subjects having low, better baseline hand grip strength were having low risk of developing symptoms of depression in future. We also can assume that improved physical activity and thus improved muscle strength might help in improving symptoms of depression. Hand grip strength and force of plantar flexion is a very objective, easy to perform method of assessment of physical performance. It can act as a proxy marker for mental health, though our study is not powered enough to claim this conclusion, but we can plan future studies where we can plan longitudinal studies to see the effect of changes in the hand grip strength or force of plantar flexion on the severity of depression of these patients, and we can assess the sensitivity of these assessments. I would like to thank everyone for your patience, and I would like to thank the organizing committee for giving me this opportunity. I'm open for questions.
You have a question?
Yeah, hello, Zoa.
Yes, ma'am.
Hello, Zoa, can you hear me?
Yes, ma'am.
Yeah, Zoa,
Ma'am, I think
you had mentioned in your study design that the age group that you had used was between 18 to 60 years. Don't you think that the results will vary in this wide age group because you are considering a variable of hand grip strength? So it's going to vary in such a wide age group. That's number one. My second question is, did you use any other questionnaire to assess depression? Because PHQ basically, I will say, it actually measures your physical ability, not exactly the depression. So did you use any other score or any other questionnaire to diagnose depression? That will be my two questions.
Ma'am, this is actually an ongoing study, which we are still taking data in for the study, where we are comparing the effect of various treatments on the patients of depression, whether their muscle strength parameters are improving after depression, improvement in their symptoms. So this is part of that study. And yes, we included a very wide range of patients, and we were planning to normalize their hand grip strength with their BMI so that we can exclude the effect of age and physical fitness of these patients. But that right now the data is not sufficient. So we could not, and also right now the majority of patients are between the 18 to 30 years of age group. So that's why we did not include that age parameter. And ma'am, PHQ-9 score is actually a depression score only, which asks questions of symptoms of depression. And it grades, not just grades the severity, it is sometimes used at some centers for diagnosis also. So it is related to depression.
Rather, one suggestion could be that you can categorize your different ages into, different groups. Say, 18 to 25 or like that. And then you can analyze your data. That will give you better outcomes.
Sure, ma'am. Thank you.
Another thing was that probably you could use the DAS scale also, as it's an ongoing study. The DAS, Depression, Anxiety, Stress scale, along with the PHQ scale, which will help you kind of further.
So we are trying to include HAM-D and other cognitive scales also to improve the correlation or see the improvement in the correlation.
And your findings were significant only in those who had severe depression, right? Their scores of the hand grip was very less. Others performed pretty fine. So it can only be used, as you mentioned in your conclusion, has to be slightly modified as a marker only for severe depression, not as a depression as per se, because there their findings are normal. So cannot be used as prognostic in the phase. You can come to know
Yes,
by
sir.
this.
So with larger data, we might try to come to that conclusion. This study is not that powered to come to that conclusion yet.
And another suggestion would be that you could probably draw a graph again for correlation to and correlate the two PHQ scales and the hand grip scores and get an equation between them. Right?
Sir, I used a scatter plot for comparison of the PHQ-9 score.
You've not displayed that. You've not displayed the scatter plot.
Oh, actually,
Do you have it with you?
Yes, sir. It was there in the presentation. I don't know whether it did not come. Can you see, sir?
No, your slides are not presenting.
No, it's not visible.
Oh. I'm sharing the screen,
Yeah.
but
Yeah, I remember seeing this. Fine. Fine. Good. Thank you. Thank you so much. Right.
thank you, sir. Thank you.
Thank you, Dr. Zoha. If any online delegate has any questions to ask, they can introduce themselves and ask the questions. Thank you. Thank you. Uh, I would like to invite Dr. A.K. Pandey and Dr. Praveen Malik for felicitating Dr. Varun Malhotra. Please welcome. A big round of applause, please. Take it, sir. Good morning, everyone. Welcome to the morning session of Epicon 2022. Next, we have symposium number 10, which is titled as Stress, Anxiety, and Depression, Cause or Consequences. The chairpersons for this session we have as Dr. Varun Malhotra, Associate Professor, AIMS Bhopal, who is a teacher and researcher by passion, and Dr. Praveen Malik, who is Professor and Head Department of Medicine at ESIC Medical College and Hospital. A big round of applause for them. I will request the chairpersons to kindly conduct the event.
So moving on to the next event, this would be the symposium number 10, and it will be presented by Dr. Kalpana Barwal. The title of this symposium is Stress, Anxiety, Depression, Cause or Consequence. As far as the symposium leader is concerned, Dr. Kalpana Bharwal is an associate professor in the Department of Physiology at AIMS Bhubaneswar. Her research interest pertains to basic and applied approaches for understanding and mitigating cognitive impairment and depression related disorders through a system biology and man to molecule approach. She has keen interest in areas of cell physiology and molecular signaling in hypoxia, cognitive, and stress physiology, and has several articles published till date in this particular field. Along with the rest of the speakers are Dr. Sandhya Verma. She is a scientist in DIPR, Defense Institute of Psychological Research. She is also a clinical psychologist. Her area of specialization is in stress management, evaluation, exam anxiety, fears and phobias. She has various research publications on topics related to mental well-being and stress. And the next speaker would be Dr. Lakshmi T. Rao. She is a professor in the Department of Neurophysiology at NIMHANS, Bengaluru. Dr. Lakshmi is an elected fellow of Indian Academy of Neuroscience in 2020. She is an active member of Association of Physiologists and Pharmacologists of India, APPI. She is actively involved in initiating and executing transformational ideas and strategies for Indian neuroscientists and physiologists. Her research alignment is broadly in the areas of the neurophysiology and translational neuroscience. May I request Dr. Kalpana to please start her talk. Thank you.
Okay, thank you so much for the introduction of the symposium as well as for the speakers. A very good morning to all those who are available offline and those who are online. Myself is Dr. Kalpana. I'm from Department of Physiology, AIMS Bhubaneswar. Well, this is my first offline conference, and I want to thank APPI for making it possible in an offline mode. Well, all thanks to the COVID pandemic. Well, talking about the COVID pandemic had not only created a fear of the virus, but at the same time, it also gave us a taste of psychological loneliness and isolation for majority of the human population. Well, I'm not going to talk about the COVID pandemic right now. I'm going to talk about an important and a pertinent topic, that is depression. Well, depression is a manifestation of such prolonged psychological loneliness and isolation in the presence of, despite physically present in the social environment. And today I'm gonna speak about the physiological as well as the psychological attributes of depression, with special emphasis on treatment-resistant depression, which is a menace that the world is facing right now, and it's gonna aggravate in times to come. Well, when I say it's going to aggravate in times to come, I say that because looking at the prevalence and the global burden that the depression encompasses on the entire population. So you can see that approximately 322 million of the people worldwide are affected with depression, accounting for approximately 3.8% of the total. And the Southeast Asian region projects 27% of all the worldwide population that are being affected from depression, which is the highest of all. And it is highest because of the lack of resources, lack of trained healthcare providers, and also the social stigma that is being attached to it. And because of this, it necessitates research in the area of depression so that we can understand the underpinnings of this particular disorder. Well, the prevalence of depression is similar amongst the adults as well as the geriatric population, accounting for 5% to 5.7% respectively, meaning that the adult population is equally affected with depression as the geriatric population. Another problem that is associated with depression is its recurrence. That is, it tends to recur despite being prescribed with the antidepressants, and also it is a progressive disorder ranging from mild, moderate to severe, and affects the quality of life and also the daily abilities. The worst problem of depression is that it tends to, it causes people to have this tendency of suicide. So over 700,000 people, they die because of suicide every year, and these are the statistical estimates from the WHO. And according to these estimates, it is the fourth leading cause of death in 15 to 29-year-old as well. So this makes the research in this particular area a pertinent one. And clinically, depression is projected as major depressive disorder. So an individual is said to be depressed if he or she is having any 5 of these 9 symptoms. So basically, they divide the symptoms into the fundamental symptoms, the emotional symptoms, the neurovegetative symptoms, and the neurocognitive symptoms. The degree and the severity of these symptoms, as it increases the functional impairment of the individual as well. Well, a lot of antidepressants are there in the market, ranging from the SSRIs, the MAO inhibitors, and the tricyclic antidepressants. But despite that, no relief has till now. We are not in a better position to completely cure this particular disorder. Well, because these antidepressants, they fail to provide any relief to these MDD patients. Therefore, this results in a concept of treatment-resistant depression. This was first given by Thays and Rush in 1995, and they gave different staging patterns so as to identify the individual who is having treatment-resistant depression. So in stage 1, refers to a patient wherein there is a failure of an adequate trial of at least one class of a major antidepressant. Stage 2, where 2 distinctly different classes of antidepressants have failed. Stage 3, when stage 2 combines with a third class of antidepressant, which is tricyclic antidepressants. And stage 4, when stage 3 combines with the MAO inhibitors. And stage 5, when stage 4 combines with your ECT. And the figures being shown here are from a huge trial till date that was done in the research field of depression, which is a START trial. It was a sequence treatment alternatives to relieve depression, our biggest trial of all, biggest in terms that encompasses almost all the countries worldwide. And it was a huge, a very, very elaborative project of $34 million. And it had given us very, very promising results. So you can see here that though the remission, the percentage of remission in case if one monotherapy or one single class of antidepressant is being given, the rate of remission is high. But as you combine these therapies, the resistance increases towards the depression. Resistance to these antidepressants increases, though the remission goes low. And therefore, because of this treatment-resistant depression, the patients, they tend to resist to these antidepressants. Therefore, the prevalence is very, very high, approximately 30.9% of all those patients who are undergoing treatment for MDD. Now, well, the high discrepancy of these antidepressants in the MDD patients, it calls for certain factors which are beyond the neurotransmitters and their receptors, and therefore we should look for other factors beyond these neurotransmitters or other factors such as the brain states. Now, this concept of brain state was first given by Gray, and he mentioned that the brain state can go either into an approach system, which is a positive kind of an effect, or an aversive system, which is a negative effect. And the balance between these brain states, that is the approach system and the aversion system, actually maintains the behavioral system of an individual. And what happens in case of depression is that there's a disbalance between these approach and the aversive systems. And this concept was given by Carver and White. And you can see here the left side of the brain is usually governed by the approach system, and the right side of the brain is governed by the withdrawal system or the aversive system. And in case of depression, there are two behavioral systems that have been identified. One is the behavioral activation system, that is the BAS system, which is the approach system. And the second is the BIS system, which is the behavioral inhibition system, that mediates the negative effect or the aversive effect. So it is believed that the behavioral activation system, it regulates the appetitive motives, in which the goal is to move towards something we desire, whereas in the behavioral inhibition system, it regulates the aversive motives, wherein the goal is to move away from something which is unpleasant. So in case of depression, there is the BIS takes a lead and it causes a positive effect to mediate depression, whereas the BAS, which is the behavioral activation system, it gets inhibited in case of depression. So that is how BIS-BAS plays a role in maintaining the balance of the behavioral system in case of depression. Now, we wanted to look into other confounding factors as well besides these motivational systems that exist in the brain. And we wanted to look into the vascular factors per se. And there's a concept of vascular depression. And this concept of vascular depression was given by Alexopoulos in 1994. The results were published much later. Several researchers have done a lot of research in this particular area. But Alexopoulos did his research in the geriatric population, because in geriatric population there are a lot of vasculature changes that are going on. So he was saying that this vascular depression can set in at a later stage. However, with today's lifestyle, the risk factors, the genetic factors, and the kind of environments we all are harboring in right now, the risk of vascular depression, it can exist even in the younger population or in the middle-aged population as well. And this was the prime hypothesis of our particular study as well. So you can see that if the vascular risk factors are present or they are prominent because of inflammation or because of the alterations in the hemodynamics, it may lead to changes in the hyperintensities. It may change to altered functional connectivity, which may change the brain functions, leading to depression. So with this background, we wanted to ask few questions in the particular study. We wanted to know whether the motivational systems which are regulated by BIS and BAS, they are associated with treatment-resistant depression, especially in the middle-aged population, middle-aged MDD patients, and whether the treatment resistance is associated with vascular thickening in middle-aged population, and whether tetrahydrobiopterin influence the treatment resistance. Well, tetrahydrobiopterin is a cofactor which is involved in the production of nitric oxide, and it involves the enzyme nitric oxide synthase, and therefore it acts as a vasodilator. So we wanted to look into this particular factor as well, tetrahydrobiopterin, whether it is having any effect on this treatment resistance. So the volunteers, they were recruited according to the inclusion and the exclusion criteria that is being displayed here. So a middle-aged population with an age of 36 to 55 years were enrolled. They were diagnosed as MDD using a manual, which is the Diagnostic Statistical Manual DSM-5 criteria, an extensive and elaborative questionnaire. They should not be having any previous history of clinical depression. So these were our inclusion criteria. For the exclusion criteria, we didn't take any of the patient who were having any head injury or any neurotrauma or any neuropsychiatric disorders, any chronic disease or any other neurological problem, substance abuse, or even the post-traumatic stress disorder. So with this, once we recruited the MDD volunteers using the DSM-5 scale as well as the HAMD, which is the Hamilton Depression Rating Scale, and then we followed them up twice. So we followed them up for 6 months and then again at 12 months. And after recruiting these MDD patients, we then categorized them into the responders if they were responding well to the antidepressant therapy, either one or in combination. And if they were resistant to that particular antidepressant medications, we categorized them into the MDD treatment resistant one. We again followed them up for 12 months, and again, according to their criteria, according to their HAMD and the other scales, we categorized again as responders and the resistant ones. So these are some of the baseline demographic and the clinical characteristics of the MDD patients that were recruited. So both males and females, they were taken. The age was 36 to 55. Education was 10 plus minus 5. Kupuswamy scale was used for determining their socioeconomic status, and the depression scales of DSM-5, HAMD were applied, and WHO DAS-2 is a scale for disability to assess the disability of these patients, and we use this scale as well. Now coming on to the results, these are the psychological variables that we had assessed in case of the baseline as well as in the follow-ups of the MDD patients that we had recruited. So you can see the HAMD score in case of the non-responders in both 6 months follow-up and 12 months follow-up. You can see that there has been an increase in these follow-ups of these patients. So it means that the disorder was found to be progressive. We also looked at the motivational systems, the behavioral activation and the inhibition systems. Now, the BIS-BAR score has got several subdomains as well. The behavioral activation system has got the reward responsiveness subdomain. It has got the fun seeking subdomain and the drive subdomain. These domains are categorized on the basis of the questions that we usually ask the patients. So on the basis of these questions, we can categorize and we can get some idea about each of these domains. And you can see that amongst all these bar scores, the reward responsiveness score was the one which actually gave us a promising result. You can see that in the follow-ups, there was a decrement in the reward responsiveness domain as compared to the baseline. Also, we found that there was a drastic increase in the disability score as determined by the HUDA scale. Then we wanted to look at the vasculature of these middle-aged MDD patients. We looked at the intima media thickness of the left and the right carotid artery. And you can see here that in the follow-ups, there was an increase in the thickness of the intima media in case of the left carotid artery. We didn't find any significant change in the right one, but we did find a significant change in the left carotid artery. We also did pulse wave velocity, but therein also we didn't find any significant change per se. We also looked at some of the physiological variables that could play a role. These are some of the confounding factors, I would say. We wanted to see if they are having any role to play in case of these in treatment resistance. Now, so amongst all these physiological variables that we had assessed, we measured the blood pressure, the central blood pressure, the heart rate, the waist hip ratio, BMI, EGFR, glucose, and tetrahydrobiopterin. Now, if you see here, if we compare the responders and the non-responders, you will see that there was a drastic decrease in the case of the tetrahydrobiopterin in the non-responders, whereas in responders, there was a increase of this particular cofactor. So, then to see the interdependence of each of these variables that we had studied, we wanted to analyze each of these variables the physiological as well as the psychological variables, and we created a heat map. This kind of a map gives us very, very better outcomes because it is a patient-centric analysis. So what we can do is that individual patient-wise, we can assess, we can correlate each of the variable to the another one. So you can see here the red squares that you see, they show positive correlation, and the blue squares, they show negative correlation. And with this, you can see that the depression severity is positively correlated with intima media thickness, with the BIS scores and the systolic blood pressure. And the depression severity is negatively correlated with the tetrahydrobiopterin and the BAS reward responsiveness score. So to conclude with our findings, what we had come out with the results are that there is a reduction in the tetrahydrobiopterin, which is a cofactor for this nitric oxide synthesis, leading to a reduction in the endothelial nitric oxide, which along with the thickening of the carotid artery leads to the vascular changes. It leads to increased arterial stiffness, as we have seen in case of the intima media thickness, leading to a decreased cerebral perfusion, though we have not seen it, but we plan to do some study on this cerebral perfusion as well. And this leads to the reduced reward responsiveness that could lead to depression. So with this, I would like to thank and conclude everyone for your patient hearing. And these are my collaborators who had participated and contributed in the study. Thank you.
Wonderful presentation, Dr. Kalpana.
Thank you, sir.
This, especially in the present era where we have COVID, it's a very optimum topic, and I would congratulate the organizers of APICON and the kind of work you're doing, because it is said that the fear of the virus is worse than the virus itself. In fact, I myself, we were doing some research, which we got a grant, I'd like to share it on this platform of DST Satyam. And we had people who, during 2 years, elderly people who have not even come out of their homes because of that depression that you wonderfully spoke about, in which you gave about MAO inhibitors, and you classified it initially and then came to your research later on. I like the concept of BAS and BIS and also of nitric oxide that you have done. So congratulations.
Thank you so much, sir.
Any questions to the audience, please, or for anybody online?
Good morning, Lakshmi ma'am.
All of us, I'm Professor Jyoti Kumar, professor and head at Government Medical College, Sonipat. That's the only women's college. Okay, everybody tends to get depressed, and it is a fact and factual. And just now, Dr. Saab also expressed that COVID has taken a lot of cases, not from the disease, but from the depression. Now, physiologically, we are in a physiological update. How can we tackle this issue? You have presented very well. First, I should have said that.
Thank you, sir.
And you have given a balance. और मुझे तो ऐसा लगता है कि ये balance है हमारे पास. That makes us work today that we are here.
So rather this, I would like to say, first of all, sir, I would like to say something. There has been a, I would say, misnomer. So we all think that, COVID pandemic had, because we were in captivity. We were inside our homes, and there was not even physical captivity. I will say that was mental captivity also. But I will not use the term depression per se, because I will say we were not depressed at that particular time. That was an adjustment disorder. So there's a huge difference between adjustment disorder and depression per se, the clinical depression per se, because we will come out of this adjustment disorder, with time. But those patients who are actually suffering from clinical depression, they are very, very, it is very difficult to treat them. Very difficult for them to come out of this particular disease, despite, so many therapies which are going on right now. Rather, they are using this BAS system as a cognitive therapy. They are using some, modules wherein they can influence or they can activate this particular system to get, this amelioration in this particular disorder.
I have some basic fundamental which I missed actually. I came slightly late and I was reading hands and so I was concentrating, but I was not able to understand what is BIS and what is BUS.
So basically, these are the brain states. I will say, in layman's term, these are positive and the negative states. So basically, in our brain, we are regulated by these positive and negative states. So it has been found that the left side of our brain is having a prominent motivational system, which is the BAS system, the behavioral activation system, and the right side of our brain is governed by this inhibition system. And usually there is a balance between the two. We try to do it normally. But what happens in case of these depressed patients, they are unable to do it because all the time, this inhibition system, predominates. It dominates in them. So always that feeling of guilt, always that feeling of, helplessness, always that feeling of depressed mood, anhedonia. So that, stays there for a long period of time. That's what when we call them as depression. But in case of, normal individuals, we do have these episodes wherein that particular state is plays a prominent role, but then with time, as we move further in our lives, that tends to get balanced again. But that doesn't happen in case of these MDD patients. Thank you. Thank you. Thanks. Thank you.
Moving on to the next speaker. May I request Dr. Sandhya Verma, please come to the dais as the next speaker. We have already introduced her, so she can start her presentation.
Thank you, sir. And thank you, Dr. Kalpana, for giving me this opportunity. So, topic for my today's presentation would be social anxiety, which is a major cause behind social anxiety disorder. And today I'll be talking about there is a need of early detection of this particular mental health condition, and will also be proposing a comprehensive intervention model. For this particular presentation, the co-authors are Dr. Vibha Sharma from IBHAS and Dr. Prashant from BML, Munjal University. Now, before I move further, I would like to mention about what exactly is the social anxiety. If you see, normally it is present in all of us, and if in case it goes higher, it considers as persistent irrational anticipation anxiety of negative evaluation of our social self, how others perceive us, by others, characterized by marked fear and anxiety about one and more social situation where a person is subjected to scrutiny or where a person will be judged in various situations. These situations may be a social interaction situation where a person is being observed, maybe during the presentation, viva, interview, etc. And when a person is performing maybe in similar kind of conditions. Now, these kind of conditions are generally stressful for all of us, but in people who are having a high social anxiety, it is very stressful. Now, I'll talk more about in the literature how SAD, that is social anxiety disorder, there are a few glaring facts about it. It is the most third common mental health issue which affects general population. My topic would be more of a general population. And its lifetime prevalence is very much. There are 264 million adults around the globe which have anxiety, and female are more prone than male. SAD is, that is social anxiety disorder. It is seen that generally it remains undiagnosed, even at the later age. I've seen even the age of 40 and 50s. And generally with a symptom of 15 to 20 years, people seek for the treatment, and even at that time, they seek treatment for major depressive disorders or other disorders. They generally don't go and seek treatment for social anxiety disorder. Patients frequently present to the physical doctors, physicians, then to the psychiatrists or mental health professionals. We have seen that comorbid psychiatric disorders are 90% in the patients of SAD. SAD is robustly related to suicidal ideation. Now, this is what we have conceptualized for this particular prevalence study. We have, if you see, we have got a healthy social anxiety which is required for survival, for doing our work, day-to-day work, and performing at office and other places. Now, in case this anxiety goes higher, it becomes distressing, and same work becomes very stressful for an individual to function, and he always remains under stress. Now, in this particular study, we are not going to take the people, those who have got a social phobia, which is more of a dysfunctional. Now, the behavioral characteristics of these people who have got a high social anxiety are these people silently suffer. The reason behind is majority of the people do not know that it is social anxiety, except psychiatric community and mental health community. Other communities, they are not aware that this is a mental health condition which requires, and it is easily treatable. Best part is it is easily treatable. And people generally, those who have social anxiety, they procrastinate, they remain absent during the school on the pretext of maybe illness or stress and all. And they lose major opportunities of the job and other important situations and job situations and the career situations. Literature have seen that these people lack life skills. Though now WHO has told schools to work on life skills, but still they lack, these people lack life skills, and they display little awkward behavior. Like maybe in case you greet a person who has got a social anxiety, that person will just move away from that place. He won't even greet back. He will abstain from acknowledging people. This is a small awkward behavior people show. And these people are hypersensitive for criticism. They take criticism as a attempt to put them down, and this further debilitates their performance later. As the moment they get attention, these people lose their confidence. They have very low self-image and very low self-esteem. Generally, these people suffer from a cognitive bias, which is a core cognitive bias, which is also known as fear of negative evaluation. They always are scared that they will be negatively evaluated, even though they are doing their best. The moment anybody will talk about or maybe interrupt anything or may ask for a clarification, they'll interpret that particular thing as they have been negatively evaluated. Now, what are the risk factors and comorbidity when it comes to social anxiety? Where we have seen in India per se, it is my, I need to again further put it with a literature review and all. In India, autocratic parenting style is much prevalent. We believe that spare the stick and spoil the child. Okay, this is major risk factor because this actually kills a child's self-image and self-esteem. Next is ill treatment of the child, maybe at home, by caretakers or at the school. Family conflict where parents are fighting, where there is strained relationship between the parent and other people, those who are present in the family. Various life stresses and trauma can also induce social anxiety in a later stage, and especially a person who has been exposed to life stresses for continuous period of time, which is also known as complex PTSD. And peer abuse, bullying during the teenage time and school time, that is a major issue for social anxiety. We have found genetic basis of the same as well. Obesity in teen, also body shaming and all, these can also lead to social anxiety. Now, what are the comorbidity associated with it? Majorly anxiety disorders, major depressive disorder, mood disorders, avoidant personality disorders, substance abuse, body dysmorphic disorders, and specific phobia, OCD, and panic disorders. And it also includes suicide. And now, what are the social anxiety? What are the safety behavior and the avoidance behavior? We have seen that people. Can I have a water, please? Oh, thank you. Okay.
Take it easy, man.
No, actually, I had bad throat. So somehow I reached here. I was having fever.
Take care. You're doing a wonderful job.
Thank you, sir.
Social anxiety thing you've mentioned.
Thank you, sir. Thank you, sir. I'll give you a slide show. No problem.
So we would like to sit or something?
No. I'm perfectly okay, sir. Just bad throat, that's it. Now, what we have seen that People with social anxiety, they are more prone for victimization, and they're the people pleasers. They do not set their boundaries. They just say yes even though they want to say no. They just take abuses, they take emotional abuses and violation of the boundaries just to avoid conflict and aggression from the people. Now they are very vulnerable for public mockery, as I told you. No, thank you. As I told you, these people are the one who cannot set boundaries. They just take people as they are, and they will keep pleasing people even if they will be dying inside them. And another thing is, as these people don't like to give presentation, don't like to be a center of attention, so that's why these people do not, they avoid giving presentation, avoid giving interviews and all. That's why they suffer a lot. This, in case it is required to give them, let's say if you make it very compulsory for give them presentation and interview, they prepare lots, so they take lots of time in preparing, and they'll have lots of chits. In my clinical practice, I've seen even people, those who are working in the military, they keep number of chits at different places, and slide will be full of things and all. They'll be preparing a day before, and even on the day of the presentation they'll be literally fumbling. And those people who are more autocratic in the office and other places, these people avoid. I've seen one of the case where these people even avoid the person. They'll just check whether the officer has left, and then only they'll go to that area. Up to this level they have avoidance pattern. And in case required, they speak pretty fast, or they'll go blank. They feel that now they can't think of the major symptoms are, they say that the word is here, but I'm not able to speak. My tongue has got stuck. These all symptoms do come. And in the meeting or in the places, what do? They generally prompt the person who is sitting at the side by doing this way and say, "Ki, you tell this story, I am not going to tell." In case you tell a person to at least you speak up, then that person stands up and he doesn't speak the entire content. They'll just say one word or two word or maybe hardly a sentence and then leave. Now, what is the cost of social anxiety in case it goes untreated? First is lower education attainment. People, even though they are very good, very capable, intelligent, but because of social anxiety, they fail to complete their education. Even if they complete their education, they are low achievers. Even if they attain something, but during the interview and jobs and all, they can't function. Now, even at the office, we have seen very people with a high caliber. These people fail to perform. They are not able to justify their caliber. Thus, they further are not able to get the promotions and all. And particularly, they have got a very low quality of life, because it later on, you know what happens, because of the social anxiety, these people are not able to maintain even a personal relationship and official relationship, and gradually they are alienated from people. And later on, it can lead up to psychosomatic illnesses and autoimmune diseases. Now, when it comes to prevalence of this study, I was a little surprised. Please guide me in case you get any study on social anxiety. Though I got many studies on SED, but I could not get studies on social anxiety, which is a mental health condition. However, I'm now quoting a study by NIMHANS, which has been done on six cities, which says that social phobia and dysthymia, this is 0.08%. And as per them, mental health problems is prevailing in 6 cities, 84.5%, and which can lead to common mental health issues, and later it can lead to neurotic disorders. Okay, social anxiety is one of the neurotic disorder and major depressive disorders. So now another study which I found was again on SED only, which was done on 7 studies, which says, if this is a graph, you can see up to what extent SAD is there in different age groups, 16 to 17, 18 to 24, 25 to 29, and overall. As per the Rose and Taddy, worldwide prevalence is 5 to 10%, and lifetime prevalence is 8.2 to 15%. And as per WHO 2017, lifetime prevalence of SAD is 1.3, 2.4, and 4%. Now, for this particular study, what we did is, we took 3 samples. We have taken students, and we have taken college students, and we have taken working professionals. In students, we have just measured academic anxiety, and which has also few items of social anxiety. Over there, the sample was 919, and we have seen 44% of students have got high academic anxiety, and college students have 38% of high academic anxiety. Now, when it comes to social anxiety, uh, amongst college students and working professionals, for this we have used SAQ30. If you see, it is very high and very alarming for all of us. College students was N, and age was 19 to 21. Working professional was 21 to 54%, and these people were from high pressure jobs, sales, operations, and business development, and all, ranging from junior to the senior most. Okay. And the study says that fear of public speaking in review, an interview, and viva, it is as high as 41% in college students and equally high in working professionals, which is little alarming for us. And speaking with authority, 41 and 34 subsequently. And again, this is a matter we need to look into. Interaction with the opposite gender, which is another dimension of social anxiety, which is 17% to 16%. And fear of being assertive. Again, if you look at this particular dimension, fear of criticism and disapproval is 35% amongst students and more in working population. Similarly, it is more in when it comes to anger expression, conflict, and confrontation. It is more in working professionals than students, and fear of rejection is more in college students than in professionals. Now, what happened, along with this, we have given job anxiety scale to working professionals, which also measures valuation anxiety, that is also social anxiety. It's, if you see, anticipatory anxiety and avoidance behavior is in 30%, and social anxiety, which includes interactional anxiety and fear of being exploited by the seniors or other areas, that is 17%. Cognition of insufficiency, which indicates low self-image and self-esteem, which is so low, and perceived self-image is 53%, and concern about public image is 53%, again, which is very, very high. Now, what happened after that? Pandemic by the time was over, we could contact these people, working professionals, and we made a group of 7 to 8 people, and the sample was subjected for focus group discussion, wherein we had put certain situations pertaining to social anxiety to find out what are the themes among the working professionals. So the themes were very much matching with the international themes, which says, except this one, I will speak in English, people will consider me backward, which was very much there in the Indian population. Otherwise, rest all themes are same. The themes are, I will forget the sequence of thought, and I will go blank, and I'll forget things, and people will laugh at me. Next one was, I will not be able to give appropriate answer to the question, and I'll be looked down upon my own colleagues and the seniors. I'll be proved failure, and I'll be proved that I'm not a competent person. And one of the very starking, physiological danger ideation, feared consequence, which was reported was the tongue will get stuck to my palate, and then I'll not be able to speak, and then I will stammer. Many places we have seen people, those who stammer, not necessarily they are stammering because of organicity, but they stammer because of social anxiety. And people notice, and another themes were, people will notice, in case they'll have physiological symptoms, people will notice, and people will make fun of it. And next one was, they will not be able to convince the clients, and then won't be able to attain the target, and they will lose job promotion. Other themes also was, one of the theme was, they will not be able to maintain the reputation of the organization, because working professionals feels that when they go out, they are actually representing their own organization. And another one was, my image will be sustained forever. Image of incompetent and low performer will be sustained forever, and my growth will be stagnant. I'll be economically suffering. Colleagues will tag me, boycott me for underrated performance. Boss will pinpoint publicly and about my bad behavior, which further actually increases social anxiety. People will call me dumb and pagal. Pagal, it was done into North Indian states, that's why pagal. Okay. I will not be able to check people when they will ask irrelevant questions. I will not be getting promotion, and I'll be alienated, and people will talk, tag me low-witted. These were the underlying fears which we further did the cluster content analysis. Now, this is a model based on the, though I understand for prevalence study, the sample is very less. We are still working on it, and we are going for further refinement of the study. But based on whatever experience I have, this is what model I'm proposing, and please suggest more improvement into it, because just a thought which I'm having. Can we have one integrated central health management system wherein everybody would be having a health ID, which will be connected with Aadhaar? Why I'm saying Aadhaar? Because it is something which is implemented, and now we can have the implementation with it, and it will be connected it. Now, my proposal over here is, can we go for destigmatization of mental health issues and making it as normal as we have made it for other physiological issues? If you look at the thing, I'm sure those who are sitting over here, you might have seen movie Tare Zami Par. After watching Tare Zami Par, the stigma pertaining to dyslexia has gone down. Okay, people are aware what dyslexia is. Can we have the similar kind of campaign for destigmatization of social anxiety and making it popular and making it normal, so that we can sensitize people? Now, I also propose the strategies include having a psychological health screening system at the schools, at colleges, and at workplaces. And when I say school, I'm including kindergarten, I'm including primary schools, etc. Can we also train our teachers to identify behavior markers? And there are very simple scales available. We can have an internalized version of the same, and we can have the list of all danger ideations, and same rating scale can be given to the teachers. They can easily identify, and they can come to know that the student is having a social anxiety, and that instead of making mockery of that student at such early age, which may later on convert into a very inhibited personality or depressive disorder, we can make the child shine and use his caliber. I also propose various movies and training videos as an awareness campaign. Along with that, various intervention strategies which will be there as a self-help strategies, because there are many self-help strategies. Social anxiety can be managed at own level with the intervention of the people around. Now, stakeholders for this particular may be Ministry of Education, Health, Industry, and Defense. I'm including Defense also, because over there also we need it. Let's not, negate it, okay? Because the same common population is at the Defense as well. And I'm also including Educational Institute primary, from kindergarten onwards, and primary health care centers from even to the remote area of India. Government and private hospitals joining hand together, along with psychiatry department, because here what I feel is psychiatry department is a little alienated. Can we all come together and join hand together, make one health system? And I'm here also including job organizations, which includes private as well as public. This is what I visualize my India, maybe in future, where I want to undo what Macaulay has done in 1835 by bringing the system. As per that time, as per this particular thing, at that time, Macaulay saw India having people with high self-esteem and high value. Where all these Indians have gone? Can we again make our India as strong as we were there in 1800 century? Let's join hand together and make our country shine again. Thank you.
Dr. Sandhya Verma, wonderful presentation despite the fact of your ill health and having
Thank you,
fever
sir.
and cough. You touched on some beautiful points which I'd just like to summarize in 2 minutes.
Yes, sir.
There's a Gita shlok on what you said on how these people, when they get criticism, they are unable to kind of withstand it. It says, Tulya ninda stuti mano santushto yena kenachet aniketa stiramati bhakti manme priyo naraha. It means that he who is tranquil before insult and praise.
Yes, sir.
He's even-minded and he's calm. That person is pure, is dear to
Yes,
the
sir.
Lord. You also mentioned something which is not trained, the concept of parenting, in which unfortunately the society doesn't have any teachers or training. It has to be a balance between love and discipline without any harsh treatment.
Yes,
And
sir.
one must encourage the children, because the kind of peer pressure which they face, as you have said in your studies with
Yes,
students
sir.
and colleges,
Yes, sir.
it begins at home.
Yes,
In
sir.
fact, there was a study in which the parents used to criticize the step parents, rather the children, and the stammer developed. You also touched on the point on learn how to say no, and the examples of defense people was quite, because my father was in the defense on a personal level, and those chits which they used because they had to overcome stage fright, unable to
Yes,
speak, not go to the
they have, they have.
authority areas.
They have.
In fact, with the students also part, you mentioned about it's like a mouse being trapped in a mouse trap. The heart rate goes up very high.
Yes, sir.
So the students before the exam, it was very relevant kind of.
Yes, sir.
Then you did a qualitative analysis regarding themes also, in
Yes,
which
sir.
they said they're not able to speak English. And tu bolle yaar, mera
हाँ
tongue
जी.
palate pe.
Yes, sir.
So all these were very relevant, and we come across them in our lives. But at the end of the day, the fruit will be born if you could probably write a proposal to the ministries that you have mentioned. Tare Zameen Par is a very apt movie which you also
Yes,
mentioned.
sir.
And similar movies should be made regarding social anxiety. It could be, I can visualize Amir Khan talking and then getting away from the side, to address this issue as even acting. We're
Yes,
not
sir.
able to interact with the people very well.
Yes,
But
sir.
my thing would be that if you could probably propose, by making a proposal, you're from the defense to the ministry, that Aadhaar idea which you had, because mental health is nowadays a very big problem which is now
Yeah.
coming
Yes,
to
sir.
the forefront.
Yes, sir.
Congratulations for a wonderful talk with
Thank you, sir.
wonderful example.
Thank you, sir. What I'll do, sir, thanks for the suggestion. What I'll do is I'll make the proposal and give it to you. Because me being in DRO, I'm not allowed to do all these things. So, apart from my job, I spend my time in the evening in doing all these things. So, I'll definitely make the proposal and give it to you. I think so. Yeah. So, I'll give a proposal. I can make out, sir. Yeah, thanks for encouragement, sir. Yes, sir. Yes. It was before the pandemic. We started at the 2019, and which end. In fact, it's not yet end. We are still working on it. It's continued. But qualitative analysis was after the third wave. Yeah. No, sir. I'm not suggesting that. What I'm suggesting is widespread awareness about it. My first step is spreading awareness. Let everybody know that social anxiety exists. The way today everybody can understand now, whether they are having a viral fever or they are having a fracture or whatever. They can understand basic, even if a person is illiterate, that person can understand fever is something. They can understand there's something known as viral fever, basic thing. Right? Similarly, this is what I'm proposing is awareness up to the level ki chote se chota bachcha, up to the dadi and nani, they can understand, acha, ye kuch social anxiety ho rahi hai isko. This is what I believe in. This is the first level. And definitely when we'll work together, I'll work on how not to further stigmatize it. Because my purpose is to stigmatize it. Like when it comes to shyness, shyness is being accepted na. Sharmila bacha hai, theek hai, koi baat nahi. Right? So similarly, can we accept social anxiety? Though Sharmila bacha or shy people are more prone to it. So this is what I'm planning to propose here. We can further work on it because it's just basic model. We will sit together and work on it. And it's required. I don't want to stigmatize it. My purpose is I've been working in this field, I think right from 1998, it's pretty long time. So I have seen stigma up to the core level in even into the psychological fraternity, not the psychiatry one, but the psychological one. Where in psychology we have different people with a different specialization. But the moment we talk about clinical, वो say, अरे ये तो पागल है, अरे ये तो पागल का डॉक्टर है. This. हाँ जी. हाँ जी. No, sir, I haven't taken. Definitely, if I work with any physician, I'll definitely take it because we are purely psychological institute, and when it comes to me working out, I have my own limitations due to working in defense. So, but when it comes to working collaboratively, I would love to work in this area because still the study is on a very primitive stage. So you were asking some question.
I must congratulate you for your brilliant presentation.
Thank you, sir.
And stress anxiety is one thing which everyone goes through. And no doubt there are two faces of each person. When you met him or her in individual, and when you
Yes.
see her or him in a social
Public.
environment.
Yes, sir.
Maybe social media, and like I have seen the previous generation who used to go to the market to even to buy vegetables, and there was a sort of interaction between the vendor and the buyer.
Yes, sir.
That has all gone. We all use Grofers, Blinkit, and they supply the product at your home.
Yes, sir.
Maybe the social media and this online buying thing also plays a role in this social anxiety thing coming up.
Yes, sir.
But yes, this needs to be, and that person was also saying there is no harm in identifying a problem or a disability. Unless and until you identify there is a problem, you cannot cure it.
Yes, sir.
There is no harm in labeling somebody as that this person or this child. Unless and until you identify the problem, you will not be able to solve it.
Yes, sir.
But brilliant presentation.
Thank you, sir.
Congratulations to you once again.
Thank you, sir.
Thank you. Thanks, sir.
Thank you.
Just I would like to add to sir if we move on to the next speaker. There was a survey which was said, what is the major cause of anxiety? And many people thought, or it was believed, that death is the major cause of anxiety. It's the biggest fear. कि हम लोग मरने वाले हैं, शरीर छोड़ने वाले हैं, going to the, like a bird trapped in a cage, and you open the cage and the bird will not leave the cage, scared, but that is not the biggest anxiety. From the person a person is born on earth till the person dies, the biggest anxiety they came to is what is going to happen next. Okay, it's so unsure. And as sir said, we are looking at these instant satisfaction machine, the mobile phones, which are using us rather than we using them. And this is actually resulting in, the instant satisfaction which one needs. And that is not available in the world. And when our desires gets obstructed in the real world, then so happens that anger manifests, anxiety manifests. So one has to cultivate, as he said, in the, like a old generation, more kind of patience and acceptance. Thank you so much. Sir, would you please like to invite the next speaker?
The next speaker is Dr. Lakshmi T. Rao from NIMHANS, Bengaluru. Ma'am, can we have you on this stage, please?
Yes, I am online. I'm very sorry, I'm not able to make it for offline mode. Thank you.
Ma'am, you're not audible, but your slides are visible. Let me just see if you're unmuted.
Yeah, I have unmuted myself.
Audible now, ma'am. Please, you can start. You can start. You're audible, ma'am.
Okay, thank you so much for organizing this symposium by Dr.
Ma'am, your slides are not visible.
Okay.
They are visible now, ma'am.
Okay, I think it's not coming.
Ma'am, you can make it full screen also.
Is it now?
Yes, ma'am.
Okay, okay. Thank you. So I think slides are moving also, right?
Yes, ma'am.
Okay. Thanks, Dr. Kalpana, for organizing this symposium for this EPICON. I'm going to discuss with you all about one of the intrinsic drive state. I think for this first audience, like physiologist, I don't think I need to describe what is intrinsic drive state. I'm going to touch upon this intrinsic drive state in the subject which are exposed to stress at early life. And all of us know this intrinsic drive state is generally at high level in the adolescence age. We know this adolescence is the future of our any country, progressive country like India. And why adolescence? Because normally at the adolescence, the intrinsic drive state is little higher than normal and the adult or at the before the adolescence age. If such intrinsic drive state is altered, for example, either increase or decrease, which is alarming because it could be a predictor for any of the psychiatric disorders in the later life. How do we test this intrinsic drive state? and how do we understand the biological basis for this altered intrinsic drives? It is the question in the by the basic scientist. And in my lab, we have tried to understand this intrinsic drive state in an animal model of early life stress. And this work is carried out by one of my MPhil students, Shruti Sharma. She is also a physiologist, and then later she continued further into the. Hello.
The slides are not moving.
Yeah, I have not moved it, so I'm still in the first slide.
Okay. Okay.
Okay, this is the work of my MPhil. Now, later on, she has moved into the PhD programs in the NIMHANS itself. And so we use this model, like an early life stress model, by in an animal model by exposing them into the maternal separation and the isolation stress at the very critical developmental time period, which is popularly known as the stress hyporesponsive period. Like in hypothalamus is very less reactive to the any stress. What we found in earlier study is there is an elevated basal corticosterone level even at young adulthood until the old age. So basic level of the corticosterone is high. It means the threshold is moved. Then all of them, irrespective of the age group, all of them show the elevated anxiety. So then when we observed this increased corticosterone and the anxiety, so we wanted to look at the behavioral validation and more particularly focusing on the cognitive functions using different models. Like we use the classical fear conditioning model to test the fear cognition, and we observed that the animals which are exposed to this stress at the early life, they show increased fear memory and reduced fear extinction. It means they are unable to inhibit the acquired fear memory. So it is very difficult for them to extinguish the acquired fear memory. And interestingly, these individuals, they show increased spatial learning and memory in adulthood. And when it comes to the cognitive functions, these animals show the increased attention, the repetitive behavior. We use the 5-chart serial reaction time task to explain this. And on the other hand, when we looked in the sleep architecture, there is an increased total sleep time. They spend more time in the sleep, and particularly in the REM sleep. And this changes in the REM sleep was associated with the altered prefrontal cortex, amygdala, and the hypothalamic activity, and also the hippocampus. So these changes in this neural circuitry encouraged us to look into the intrinsic drive state. Any cognitive functions when we talk about it. So it's basically, it is decided by the intrinsic drive state. All of us know that if there is a drive state is high, the performance is also very high. So hence we thought we will try to estimate the intrinsic drive state in animals. So one of the important neurotransmitter when we talked about intensity is the dopamine. So we know that dopamine is known to regulate the emotions and motivational behavior through mesolimbic dopaminergic pathways. So this is the pathway, all of you are familiar with this. And as you can see here, like, there is a predominant, okay, this is the major pathway, like this is the striatal pathway and the nigrostriatal pathway, and this is another with the mesocortical and the mesolimbic pathways. So what is the importance of this, what are the functions of these pathways is nigrostriatal pathways, like this is important for the motor functions, goal directed behavior, reward related cognition and learning. And whereas the mesolimbic and mesocortical pathways, that is a ventral tegmental area to accumbens, nucleus accumbens, and the prefrontal cortex, they're important for the reward related positive and negative reinforcement, incentive salience, aversion related cognition, and decision making. Again, there is no clear delineation between the nigrostriatal pathway and the mesolimbic and mesocortical pathways with related to the cognition and the learning. So, but in any case, in either of these pathways, they're important in terms of the motivation behavior, and it could be extrinsic drive state or the intrinsic drive state. And in the today's lecture, I'm going to give you a data wherein we show that how the intrinsic drive state is altered. And why intrinsic drive state and dopamine here? Because any changes in the dopamine can be either excited or inhibited by reward circuitry and the aversive stimulus. And these either rewarding or aversive stimulus in turn alters the mesolimbic and the mesocortical pathways by altering their attentive information processing and the performance. Again, so I may not be able to explain you our data about these pathways in terms of receptor modulation, but I'll tell you what we observed in terms of neurochemical pathways and the drive state by estimating the behavior. And first, as in a validation, what we did was we exposed these animals into the early life stress by maternal separation and the isolation stress, and we found that there is an increase in the plasma corticosteroid at the basal level, at the P30 level, at a very early adolescence period. And these animals did not show any changes in the stress hormone at the P14. It means immediately after the stress, during the stress hyperresponsive period, there is no increase in the corticosteroid level. The changes in the corticosteroid level is seen delayed time point. It started from the PND 30, like the early adolescence period in rat, which is equivalent to the human adolescence also. And in terms of the anxiety-like behavior, we have observed, we used several parenting to understand or estimate the anxiety-like behavior, and we found that these animals show the heightened anxiety-like behavior when we expose them into the anxiety-provoking environment in a light dark compartment chamber. So, for example, when we expose them into the brightly lit environment in this chamber, they immediately go to the dark compartment, which is a comfort zone or the safe zone for these rats, and they spend more time in the this dark compartment, indicating that they show the elevated anxiety-like behavior. So, this early life stress model by maternal separation and isolation stress is functional. So, this is validated using the corticosteroid level, basal corticosteroid level, and the anxiety-like behavior. Then we looked into what is the basal plasma dopamine level. Interestingly, the stress at early life caused an increased almost 200% increase in the 200 to 300% increase in the basal plasma corticosteroid in these animals which are exposed to the stress. MS means maternal separation stress. Then what is the consequences of increased corticosteroid anxiety on the intrinsic drive state? What we did was we used the open field maze, which is an open arena in which rats are allowed to explore freely in this big maze. So what we observed is these animals showed, like as you can see here, they show the increased they moved across the chamber. They explored more in the this maze chamber, like an open field paradigm, and their velocity also relatively increased, even though it is not significant. And then we also did the novel object recognition test. So it is like two types of objects are given, and it is found that they do not show the interest for the novelty. So this test is basically to the familiar and the unfamiliar objects. So if they are, when it is repeatedly presented with the familiar and then added with the unfamiliar or the novel objects, and then it's an indication of the exploratory behavior of these animals. And interestingly, these animals show the reduced time spent in the novel objects, indicates there may be a possibility of these animals exhibit the neophobia. Okay, so this is the basic one. So there is a changes in the spontaneous exploratory behavior in these animals. So then with that, this would help us in understand the intrinsic drive state. We designed an interesting paradigm which is designed indigenously to understand how these animals show the how to evaluate the intrinsic drive state in the animals, particularly in the rats. What we did was, this is a paradigm where you can see that there are two platforms, and in the center platform, it is filled with the water. As you all know, rats do not like to swim in the water, unlike other mammals. So, and the reward, like non-palatable reward, which is objects, are kept in the platform where in the box where it is filled with the husk, and these objects are hidden in this platform. So rats are placed in the safe zone, which is where there is no rewards are kept, and they're allowed to explore freely here. So then this rat is allowed to cross freely between the two chambers, and in order to retrieve the objects in the unsafe zone, they have to cross the zone which is filled with water. So if the intrinsic drive state is very high, and only then they cross this water zone or the risky zone to retrieve the objects. So normally, so what we did was, we quantified the latency to cross this safe to unsafe zone through the water zone. Then number of objects retrieved, these things we have quantified. And interestingly, we found that animals which are exposed to stress at the early life, they cross this risky zone, which is filled with water, very quickly when compared to the controls which was not exposed to stress at the early life. And this indicates that, so the early life stress is maybe one of the cause for the enhanced intrinsic drive state, increasing the curiosity in these animals. So then again, we did the curiosity index, and we found that curiosity index in this animals, like MS stress animal, was high when compared to the animal which are not exposed into the stress. Okay, as I told you earlier, these animals also show the increased dopamine level. So in summary, the animals which are exposed to the early life stress, they show increased basal corticosterone, which is associated with the increased anxiety-like behavior when you expose them into the anxiety-provoking environment. And they also show the increased dopamine level, and this increased dopamine level was associated with the increasing interest in drive state, and on the other hand, there is increased curiosity-like behavior. What is the consequences of this intrinsic drive state? So if the drive state is very high, so one of the predictor for this is we expect elevated curiosity could be the positive factors for it may predict the high risk for addictive behavior at adolescence period. So with this, I would like to thank you for the organizers allowing me to speak online. And this work has been particularly the curiosity like behavior in these animals we have published in the already in the publish, and this is the work of Shruti Sharma, current PhD graduate. And this I would like to thank the collaborators, Srinivas Bharat in the dopamine assay and other things, and Yoga Narasimha. And I would like to thank the funding support like CSIR New Delhi and NIMHANS Bangalore for providing infrastructure facility. Thank you once again to organizer. It's been a wonderful journey for me to be associated with the physiologists of India. Thank you.
Thank you, Dr. Lakshmi. In fact, what you said actually summarized what is written in one of the Chanakya Shastras, which says, if the child is less than 6 years of age, he should be given lots of love. Yes. Lots and lots of love, because the mother's love, as you had mentioned, is so important, and mother's separation leads to anxiety, which you had scientifically proved. They say between 6 to 16, it should be a balance between love and discipline. And after 16, the children become your friends. But the upbringing, early stress is very, very crucial. You showed this through the dopamine pathway, the motivational areas, And something which I also realize is somebody is in stress, the dreaming states increase, though the spatial and verbal ability also does. So a little bit of use stress is good. I would like to share a joke with all of you. This was in Lady Harding Medical College, which was about 5 to 6 years, I believe, before. Dr. A.K. Jain, who's written so many books in physiology, was speaking on the physiology of stress, cortisol, CRH and all. And he was getting towards the end a bit monotonous, so he cracked a joke. He says, कि अगर stress कम करना हो, if you want to decrease stress, शादी कर लो, get married. It doesn't end there. Dr. Deepak was sitting there. He was here a few moments before. And he says, अगर stress बढ़ाना हो, if you want to increase the stress, दो बार कर लो. Thank you, Dr. Lakshmi, for that wonderful presentation. And for the team, we've also finished in time.
I thank you all the speakers for their wonderful presentations and bringing insight to us regarding depression and stress and anxiety, which is very prevalent in today's world. I also thank the chairpersons, the distinguished delegates, and the audience for their kind listening. Now I request the chairpersons to please come on the stage and felicitate the speakers. Dr. Kalpana Bharwal, ma'am. A big round of applause. Now I request Dr. Sandhya Verma to please come on the stage. Now I will request Dr. Divya Srivastava, Professor SN Medical College, to please come on the stage to felicitate the chairpersons. Thank you, ma'am. Thank you, sir. So that was a wonderful symposium. Next, we have symposium number 11 with us, the topic of which is medical entrepreneurship, confluence of academia and industry. The chairpersons for this session, would be Dr. Kalpana Bharwal and Dr. Lakshmi T. Rao. I request Dr. Kalpana to please come forward and take the chair. Dr. Kalpana, we have already heard, is a brilliant orator, and she is Associate Professor in Department of Physiology at AIIMS, Bhubaneswar. Her research interest pertains to basic and applied approaches for understanding and mitigating cognitive impairment and depression-related disorders through a systems biology and man-to-molecule approach. She has keen interest in areas of cell physiology and molecular signaling in hypoxia, cognitive and stress physiology, and has several articles in her name. A very welcome to you, ma'am. Dr. Lakshmi T. Rao is present online. She is a neurophysiologist with 25 years of academic contribution and 20 years of research guidance and administrative contributions. She currently holds the position of Professor of Neurophysiology. She has more than 30 international journal publications and more than 100 publications. She has been a motivator and has driven solid scientific temper among scientists at NIMHANS and triggered scientific temper among public to create strong youth scientists in India. She was an elected fellow of Indian Academy of Neuroscience in 2020. She has championed initiatives of academic programs, students participating in reputed international and national conferences and competitions. We welcome you, ma'am. Now I request the chairperson to please conduct the event.
Okay, I welcome everyone for Symposium 11. It is entitled as Medical Entrepreneurship, Confluence of Academia and Industry. The symposium is a hot emerging thrust area in physiology in today's time. In this symposium, the speakers will showcase medical physiologists as entrepreneurs, a perfect fit. They will talk under 4 headings, from data to devices, designing apps, software, and patents. Confluence band challenges in device development, the academia industry axis. They'll also speak on machine learning, signal processing, and data management tools. And last but not the least, they'll talk on the emerging trends in the physiological techniques. So we'll begin with the first speaker. I'm honored and delighted to introduce Professor K.K. Deepak.
Madam, can I start?
Ma'am, if you just allow us 5 minutes, please.
Okay, fine. Ma'am, you can introduce Professor Deepak and the other speakers in the meantime.
Okay.
It will save time.
So it's my honor to introduce Professor K.K. Deepak, known to everyone here in the forum. He is the Dean Exams and Head of the Department of Physiology at AIIMS, New Delhi. He has set up the first autonomic function lab in India in 1989 and vascular function lab in 2000. He significantly contributed to the manpower development in the country in the field. He has been entrusted in innovations in medical research and worked with Indian Institute of Technology and other engineering institutions. His interest in space physiology and yoga resulted in the development of innovative devices. As a recognition of his efforts to apply physiology to human health, last year he was invited to chair the committee to finalize various physical activity and their assessment protocols under Fit India program of Government of India 2020. The next speaker, Dr. Pradeep Bade. He is Associate Professor in Physiology in AIIMS, Rajkot. With interest in development of medical devices, he has an international patent in medical devices. He has developed indigenous high-altitude hypoxia simulator and has several publications to his credit. He is currently involved in an extramurally funded research project by DST Satyam, which involves studying the effect of various mind-body relaxation techniques on health of COVID-19 healthcare workers at the Department of Physiology at AIIMS Rajkot. He's also working on a research project in medical education technology on peer-assisted learning in physiology for ITCOM. We have Dr. Anita Talwar, who happens to be my teacher as well. She taught me in my master's, so I know her very well. She is the managing director of Gentech. She has obtained her PhD degree from VP Chest Institute, University of Delhi. She has 14 years of teaching and research experience in medical physiology. Her forte is in cardiovascular physiology and pharmacology. She has several publications in international journals to her credit. Subsequently, she made the transition from academics to industrial interactions. She started her own venture with Gentech Marketing and Distribution Private Limited. Being a physiologist and an ex-researcher, she saw the challenges faced by scientists in India. To overcome them, she stepped into the industry. The vision is to see Indian researchers with the highest credibility integrated with innovation. And we have Dr. K.P. Kochar. Dr. K.P. Kochar is currently working at AIIMS New Delhi as a professor in Department of Physiology. Not limiting to medicine, Dr. Kochar has earned degrees in literature. She has done MA English, Diploma in French, Pragya in Hindi. Her area of interest being nutrition, Indian diet, integrative physiology, cognitive physiology, ethics and medical education, medical humanities, and she has done an extensive research work. Her latest project being a brief review on altered gut microbiota and metabolites in Parkinson's disease has gained a lot of attention, and she had 53 published articles to her name.
Thank you so much.
With this, I will welcome Madam to please start her talk. Thank you.
Thank you, and I welcome all the distinguished dignitaries present here and my young physiologists and budding innovators. This was an idea which took seed many years ago, and Dr. Deepak, who is here, is our prime innovator, motivator. Then following the same family, Dr. Ashok Jarayal, he is what I really call a true physician, teacher, scientist and innovator, or physiopreneur. And so also my dear colleague Pradeep Berde and Dr. Ashlesh Patil. And obviously we don't have boundaries these days, and therefore my very dear colleague, if I may say, Dr. Anita Talwar. So we'll try to tell all the distinguished physiologists that you all have seeds of innovation in you, and how you can become an edu entrepreneur, a physio entrepreneur, and even I can say a presentation entrepreneur. So I will not take much time. Primarily my talk is based, when I was searching the same topic in Google, I found a few things, 2 or 3. One, the success stories and narratives of people who have ventured into this, and homework for the young physiologist. Please read out what is a unicorn, what are startups. Unicorns are startups which attract funding of at least maybe $1 million or $1 billion, and what are angel investors. And we need to have networking, multidisciplinary, that is the way forward. So Harshita, our MSc student, she's also a social influencer and keeps putting videos on COVID, and a very bright girl. Khushi is a short-term training with me from University of Delhi, and she's also an innovator in graphic design. So they help me. So those who understand market needs and can connect better with customers, here customers could be our students, they could be our junior colleagues, they can be the market funding experts or investors, they can also be companies like, you know, we interact too much with Gentech and Aerobe and AD Instruments and like that. So we need to be friendly with them, and we fill this gap because each one of us doesn't know obviously everything. So we need to join with complementary skill sets. And these are all to reach success. You all can see that article, The Physiologist 2019. A young Indian girl, Purnima Apte, wrote it, and it was cited in the American Physiology Society entrepreneur endeavors. These days, the ecosystem is expanding. Many universities in the UK and USA are doing BSc in physiology along with entrepreneurship skills. And I guess, Professor Deepak, we need to take the lead in this also. So these are 3 people whose success stories are mentioned in the Physiologist magazine 2019 issue. And I am not going to read this and not take time from my distinguished speakers who were kind enough to join hands with me. So we need to protect our IPR, so it is better to put in a provisional patent application. And from what I know, Professor Deepak and has, he tells us right from the start, even if you put in that application, you have that imprint, and then funding to attract funding, and also launching of your startup, and not leave it just to diagnostics, but also give some hope of therapeutics or theranostics. So, yeah. So I'm not going to read my slides. These are people who said we are all trained as scientists, but these skill sets are transferable and we can apply these skill sets in many different venues. Even in the kitchen I do many times. So people need to know that, and we need to convince our public as well as our funders. So physiologists are uniquely positioned to understand the multi-organ system interaction. Yesterday also, when we had the symposium on clinical neurophysiology, Dr. Jaryal was present, Dr. Deepak was present in spirit, and Tripadeep Singh was present, Mrinal Pathak was present. They are all innovators. So there is so much opportunity for us to add value, to add a perspective or a context. And he was here yesterday. He is also one of the, from India, success story of a physiologist, a teacher in a university or a medical school, then having some international experience, and now starting a startup in sleep-wake science. And to succeed as a medical entrepreneur, we need to be collaborating with other people, you know. So as I told Dr. Pandey also yesterday, he's a conference-preneur, you know. At the drop of a hat, in 2 weeks, he can hold conferences and have very successful ones. And I think ESIC, I must compliment, has been in the news since its inception. So this is a slide showing which are the courses which are there, like University of Manchester, UCL. We also have a memorandum of understanding AIMS has with UCL, and also Michigan Medical School. There are so many others in Dublin, Ireland, and in. Then another important initiative I wanted to introduce was the Center for Medical Innovation and Entrepreneurship. The DBT had funded this as a BioNest, and we just give them the ideas, and they have the venture capitalists to fund our ideas and take it to a deliverable or a product development or a device development or even a technique development. So this was a webinar. I've just taken this slide. So BIRAC is helping us, the BioNest incubator. So innovators need incubators, and we at AIMS Delhi are also ready to help you. And thank you so much. Now it's my pleasant duty to start and invite Professor Deepak. Chairperson, ma'am.
Thank you, ma'am. Thank you so much, ma'am. Welcome you, sir.
Good morning, everybody. I'm very happy to be here, and good morning, Sabhi ko namaskar. I'm very happy. This topic is actually a confluence of health sciences, engineering sciences, all of the time. Look at the speaker and look at the content, and that's the best way. And at times, these fringes, interfringes are more productive than actual science most of the time. You have to take them forward. So what I'm trying to say, this is the best example of confluence. Not only health sciences, we are also bringing engineering, we are also bringing entrepreneurship, the industry people. Until unless you break these barriers, you can't take your product or your thought for the useful entity. What are we here for? We are here for to take our ideas. Am I audible? Yes. Yeah. Ideas to forward to the society. Who is the society? We ourselves can be society. So we can be user also. And so the whole thing goes around. If physiologist needs a equipment, who will make equipment for the physiologist? That's the question I'm proposing, and some answer will come through these processes. So I must thank you organizers, and without doing much formalities, how much time to have chairperson ma'am? Okay. 20 minutes. Thank you so much. I'd like to do justice. So I'm talking about the medical entrepreneurship, physiology, and industry. So look at the two ends. Quite basic in medical sciences. Industry, the final frontier for delivering thing. Not only final frontier for the delivering, which is the first thing, also to business, also to make money. I'm saying this because many of the young people, they have a target to become a physiologist, maybe, teacher, maybe, researcher, maybe, or millionaire. So who doesn't want to become a millionaire? If you can do all things together, and here lies the trick. Here lies that you can be all. And the examples were shown before. And so we have the example that you can do academia, you can tie up with the industry, you yourself can become an industry. and for yourself own consumption, some kind of equipment devices. So that is the whole thought that we. So I give you some example where we failed, and it's always to see the example where we fail and learn from them. Way back in 1992, exactly 1990, when I was senior resident or so, I devised this equipment, and we didn't know what to do with this equipment. I used consumed device for the teaching purpose, so teaching, postgraduate teaching has been done. And this is, the whole article is available on IGPP now, you can go through it. Did not know that this could be part of kind of a industry, this could be part of further advancement. My eyes were open, but somebody picks up and says that this has a useful entity. And who picked up this equipment, which was designed right over here from the stuff not used at that point of time, that is a respirator for the dog. Lying on one side, dogs were not there, so it was lying. I converted the whole thing into a kind of a blood pressure simulation model, a physical model that works. I can show you the blood pressure. So NASA picked up this. They thought it's a device, a useful device. They miniaturized it, modernized it, put under LBNP chamber and take a flight, parabolic flight, to see what is happening to this model when you change the gravity. See, look at, I never thought of that. But this is a useful for them, they thought and they used. They wanted to study what happens to intramural pressure in the vessel wall when you produce a pressure generate in an oscillatory manner and take it into space. And so knowledge has been consumed. They might have used this knowledge for safety and well-being or research of astronauts. So many of them have gone. I did not make a patent. I did not know. I did not take this to the industry so that we can create hundreds of them or 500 or 600 so that it can go to any of the medical college and can be used for the teaching what we are teaching our postgraduates. So we are using this equipment for teaching our postgraduates. Now we use software-based simulation or some other kind of a simulator. So look at the application of your thought and idea may be enormous. Multiply, use it. Create solid theoretical knowledge, use it. Or sell the idea. Or somebody might have given the idea at that point of time, I could have become an entrepreneur itself. I could have left everything, okay, now I change my compartment, I become entrepreneur, I produce hundreds of thousands of this thing and distribute, and then maybe I could have sold to NASA then. And I could have been easily millionaire. But anyway, I never wanted to be millionaire, I wanted to be a physiologist, so I'm here and you are listening. So this is one story which is like unfinished. This can still be taken by anybody. I don't think it has been patented. Now it's an old idea. However, you can put a new wine in the old bottle and you can still convert it into a software, hardware based, or you for studying so many things in cardiovascular system. Based on this and other things, I am guiding IIT Madras students to create hybrid models of circulation, like impedance based and other based. So that's this is a separate story going on. So coming to the crux of the talk which we're talking about, what happens to the research idea? I told you, I gave you one example where we did something and then finished. Okay, I earned because I published, so this becomes a very citable paper, and that's why my work is over. So I'm giving some other example here. If I look at here in the triangle, suppose we did a research long back, and that can exercise treat opioid dependence syndrome patient. This was full-blown research, PhD was done, beautiful finding. It was shown that if you do exercise, by using the naloxone, you can reverse the changes which have been caused by opioid. Beautifully shown, autonomic and doing exercise. So autonomic changes, they could reverse this if you do exercise. And we used a naloxone reversal challenge test. That was done in human being. That was an idea. Suppose I could have taken further this to idea, considering for industrial application. How could I have done? Can exercise help to improve mood? So I'll make a device which can measure my mood. I do exercise. In terms of mood, it might give you endorphin values. We know runners high. We keep on running and then no. But how many people are producing endorphin in what quantity? That's not available. It's only the test which I can do. So therefore, that can be done. How exercise influence opioid when I'm actually running. That's important. If I'm not getting runner high, why I'm not getting? Or somebody's getting more. That's how. So somehow you can do clinical application, applied research, or pure research. So sorry for the mistake. This is a pure research. So from here you can move from this to this. And once you move from this to this, you can have industrial or applicable. So somehow from here, how naloxone can be used for the research, there can be an equipment with presence of physical exercise and equipment to measure opioid level. The whole thing, if I have a patch somewhere, I'm running, it tells me you got your endorphin levels and you must be feeling happy, or I feel happy and therefore. So these things are important. Several things, it could be pharmaceutical research, it could be electrophysiology based research, or some other marker can be used. Therefore, healthcare devices can be developed from any idea. But I can do only this part comfortably. Too much there. But if I am to go to this here, I have to get somewhere some people, those who are expert on this. Device development, who can do it? Someone who can measure, or some other device. Suppose I want to use some radio isotopes to quantify my opioid endorphin molecules. I have to go somewhere with those who are expert. Therefore, it's important to handshake with people and then go ahead. Then we go further. What is the story of development of a product or device and for whom? I've taken an example of starting from physiology, finishing with physiologist. We could not measure, it's very difficult, so we have to still do it. We could not take a small sample. Therefore, I am a physiologist and I want that kind of equipment. How to circumvent this problem? What is the story like? The story like is that you have an idea and many people have an idea. There are many brilliant people, you're getting an idea now. The only thing you document it, and if at all, patent it, if you can patent it. If you patent, you protect IPR. If you don't patent, don't worry about it. The idea can still be taken for the validation. Who will do validation? You are the best person to do validation. If you want external validation, give to your colleague of some university, device development or idea, you can give, and validation. Once validation is there, this is validated device or idea. Who will do what next? The next is give it to someone. There will be transfer of technology or TOT. You have to make that effort. That's the process itself. You have to call someone. You have to sit together. You have to make an agreement. You have to make understanding. And once TOT is done, who will take it? Some industry who is interested in it, who understand your ideas, who wants your ideas. Many of time, industry is not interested in your idea, and you don't know the industry, because the potential of industry here, they are mostly driven by the market forces, not by individual. Market forces determine what will be sold. So who will create the market? Actually, this market is directed towards to a physiologist. I put the physiologist here. It could be physiologist, or it could be anybody. So then the market. What is the market now? What is required? If you look at market, some of the magazines, you would know the market behavior perfectly. Like simulations are in the market. They were not there 40 years ago. Nobody talked about simulation labs. Computerization. Cordless devices. Devices which can measure your things without any disturbances. That is the market, current market. So if you understand. Therefore, if the physiologist becomes an entrepreneur from here to here, I develop an idea, I nest the idea, I get validated, I become entrepreneur. And if I become entrepreneur, I understand this side, I understand other side very well. So therefore, I give you an example of the same what I told you. There was an idea how to measure blood flow from hand non-invisibly, Dr. G.D. Jindal, Bagh, 1980s, talking about 85 somewhere. They had an idea. They developed a device in just 10,000 rupees in their laboratory called medical modular labs in Bagh. If you happen to go, you're not allowed normally. If you happen to go, you'll see medical electronics lab. They developed the idea. Now, for the validation, they waited for nearly 25 years and there was no taker for validation. Dr. Jindal happened to come to Auto Function Lab. He saw a lab. He was evaluating our project, and soon after evaluating, he says, you are the right person to take our device and give your validation. We took that device. And then the guy sitting here for the birthday happened to be doing MD. So we did the validation, perfect validation, left, right, up, down, everything validated. We published it and they were so happy. They were so happy, then we went for TOT. How to go for the TOT? The Dr. Jindal told, you are the best person. You call anybody you want and then convince. Now, validation requires a little tricky process. You have to validate and convince someone. Whom you want to convince? Here, physiologists and industry, both two people. That time we called, I don't have a picture right now, we called top people from physiologists, named HODs, starting from Dr. A.S. Mental, several HODs on one side, cardiologists and dermatologists, those who could use this device. And on other side, we called industry people. L&T Medical was on top. So L&T Medical takes it, 2008. The product becomes so famous, Government of India Gold Peacock Award was received by this product. It's called Nycomone. Whole L&T was bought by Scanway, not because of this, for something like, now that equipment goes to, the cost here was 10,000 rupees, when gave 40,000 rupees, 1 lakh something, finally, when I checked last time, it became 2.5 lakhs or something like that. I said, then you are not doing good for physiologists. Which physiologist will buy this equipment in 2.5 lakhs, in 3 lakhs he can get import machine. That's a market behavior. I can't control it. But if I'm an entrepreneur, I can do something like that. So this is Nycomone. So this is market world, it's still there. Non-invasive cardiac output monitor and consumer physiology. So that's his story, and therefore it suggests that some of us should become entrepreneurs. So this is the real story which goes in device development. Look at, soon after this, there was a full-length article published in Bagh newsletter. Look at the title, 25 years of impedance plethysmography. That point of time, which means for 25 years the technology was incubated, lying, waiting for someone. If physiologist is there, it will be much less. Even if it is 10 years or 5 years, we would be happy. Technology takes a lot of time to come out. This is the picture I was talking about. And you should, the picture is not coming well. Chairman Sri Chitra Tinul, Snehanand, IIT Ulki HOD, Electrical Engineering, and Dr. Jindal, DST Chief of Device Development, and several other people. This is one of the picture of TOT, because DST was involved on one side and other people were on the side. So this is a successful story of at least one equipment development which has gone ahead. Now this would be the last slide to take. As I told you, you all get ideas. Anybody in India is full of idea generation. You're getting ideas now. So develop by which we should have an idea. I remember in Auto Function Lab of 20 years ago, myself, Dr. Sudhyal sitting, I said, how to get these ideas, catch them. So we kept a bottle. It's called a fish bowl, still there, they all know. So I told all students, anybody, if you get an idea, just put it. And after 2 years, after 2 weeks or whatever time, you take it out, because idea takes time to mature, to understand. You get a brilliant idea now. For example, how can I dance? How can I dance on Mars? That's an idea. Now, dancing on Mars with 1/3 of gravity, if I do like this, my head will stop if I'm in a room. So I need some device. This is an idea, but it will take 30, 40, 50, maybe 100 years to mature, mind you. Not before 100 years, some dancer is going, Shobna Narayan ma'am, to Mars and giving a dance on a Mars. She has to be trained like that, otherwise. So this is an idea. So you all have idea. So several ideas which have been actually like a novel anti-gravity suit astronomy. We have done the validation. It is published. FER we have submitted last week. Hopefully it comes. So it takes a lot of time. 2016 and we are still not yet. Who industry will take? I don't know. An isometric exercise device for undergraduate postgraduate teaching. Patent has been filed. I am waiting for TOT and harping on for TOT to all left and right. Kindly give me a TOT. Which industry I should give? If I give to someone, they should not say I have a conflict of interest. Because it will learn money, it will bring money to. So one of the important factors in TOTs and other things, the ethics of behavior, ethics of business, conflict of interest, I cannot give to my family members, I cannot give to some company whom I know, I cannot give to some company from where I'm buying the equipment. So that's what one should be avoided. So I'm waiting for my proper format. The format is your institute will say that you can do TO2 by this platform. What platform? NRDC or KIHT. NRDC is National Research Development Council. Who will find a partner for you? They will do auction, they will do and they know the business. They are in the market. I'm not in the market. I might sell my things which is very costly in a small thing or vice versa, depending on. So this all, you know all 2G case which is a problem. So this is a teaching device you all going to should use, must use, you should see an isometric device by which you can quantify the force generated at different length of muscles. The initial fog experiment which you used to do, this has been replaced. Air-cooled, breathable, single-piece bodysuit. Because of COVID, we devised, this has gone anytime it will be granted. It has gone through all stages. It's a breathable because you will not generate the heat load in the body. So simple idea, we have fixed the fans in this and adjusted. So this has been filed. Controlled artificial gravity generating bed, which is an offshoot of the first this thing, so that you can generate artificial gravity. If I'm sleeping on a bed in a space, I am not flying, I am still feeling some kind of a gravity on a back side, so you can. So this has been filed, we are waiting. Digital ergograph and method is very nice, interesting story. We took up a project with Ayush. They asked us to evaluate the function or effect of Arnica montana, which is a homeopathic drug, on fatigue. They say it's a clay. So how to do it? I went to UG lab and they asked me how to do it, Morse ergograph. When we started doing Morse ergograph for the research purpose, we had a problem. For teaching purpose, fine. You do the record, fatigue, so much time. But for the research purpose, it didn't give clean record. We had a problem. So now what we did, okay, we computerized that about 7, 8 years ago. After that, we found that this is something which can be developed into a product. We took up another project, intermural project, to develop a product. This has been developed. Now it gives you a lot of value, computerized value, it gives you velocity, it gives you frequency analysis, everything about the fatigue. And it gives you a beautiful Excel sheet at the end of the Morse ergograph. This has been filed. And I'm asking that this should go to all medical colleges now. Instead of using old Morse ergograph, use this. And you can do research, teaching and everything. So we are waiting for TOT. We are planning to give it to FITT, which is a incubation cell in IIT Delhi, a well-oiled structure which can find out in the industry part. Now, there are chances one of us can become entrepreneur if somebody desires so. So one of the, if they become, they understand the technique and they can convince the consumer or the end person, which could be a physiologist, very nicely, rather than industry convincing who doesn't know about the history of Morse ergograph. Morse ergograph survived more than 100 years. This is the only equipment, if you see so many things, which has not changed the shape. Since the beginning, 100 years almost the same, but now it has shape. This is one. The other is controlled push-up exercise device for astronaut. Again, offshoot of this. So if I have to do push-ups in a space, how will I do it? So we devised, again, patent has been filed. So I don't know how many patents will take the shape in the future. Like in Three Idiots movie, it tells us what is the fate of the egg. Nobody knows where does it go. Therefore, we do not know how many will survive. But our effort should be to do our job. File patent. If one of us can become entrepreneur, that is the purpose we wanted, some of us. And people have capability. So with that, I come towards some more topic. I have 4 minutes or more, 3 minutes more. Madam Chairperson, ma'am, how many more minutes? Time is up. So I say there's a hidden antagonism when you do this kind of work. Your colleagues will say, why are you doing? Maybe they don't understand, or maybe you will become a millionaire. So that you got to. Then what begins, it ends, and what ends with the begin, that depends. After one equipment, I can begin with another. So the concept of physiologist entrepreneur is very much, I must thank you, the beginner of this symposium, Professor K.P. Kocher, and many of the environment which has been, and therefore it is coming up. So it's a well thought, it's a good thought. Some of us should become entrepreneur if you want to reach out with society, industry, and others. Thank you so much. Thank you.
Thank you so much, sir, for deliberating the success stories of medical entrepreneurs. I think the young fertile minds as well as the academicians and physiologists who have heard you will come up with brilliant research ideas and will become successful entrepreneurs in times to come. Thank you so much.
God bless.
Now I invite Dr. Pradeep Bade to come and give his deliberation.
Good afternoon. Good morning, just on the border of morning and afternoon. Very interesting again. Mike? I'm okay, I think. Yeah. So, considering the topic that I'm going to deal with, quite complex in the sense of nothing is established and all are anecdotal examples. So far the India is concerned, we have so many examples we hear from each other. Somebody has done this, somebody has done that. But there is no structured path that is easy for somebody to pursue. And that is a real challenge. And we all are sitting in our own homes, boundaries, walls, or cubicles. And there is reinventing of the wheel many times. That is not required and wastage of effort. So around this, if we see that we start with the academia, and then within academia also, there is a healthcare segment that we all, including doctors or the technical people who are working in healthcare, and non-healthcare segment, maybe the other aspect of the people who directly or indirectly contribute to the technology. Now research can be a basic research and applied research. In that also it can be a lab-based research or pure clinical research. Now if you see parallelly, industry is everywhere. It is the driving force, as Dr. Deepak rightly said. And industry is driven by the market needs and what people require. I devise a particular instrument, and it has no takers, or it has few takers, or it has only academic interest. Then there are no buyers. Then that idea is very brilliant. We may get an award for that, but the life of that product or the importance of that product is limited to a group of people, and then you don't reach. Now if you see physiologists, my selfish interest, I must say here, that how to reach to the society as a physiology, because काफी लोग मिलते हैं, पूछते हैं आप करते क्या हो भाई, फिजियोलॉजिस्ट हो, करते क्या हो, फिजियोथेरेपी करते हो. This is most of you must have, and at that point you don't know what to answer. You answer many things. हम ये करते हैं, बच्चों को पढ़ाते हैं, रिसर्च करते हैं, कंट्रीब्यूट करते हैं. That means एक को एजुकेट करोगे आप, ऐसे कितने लोगों को एजुकेट करेंगे हम. So this one of the webinars we had, one workshop we had, and in one talk Dr. Kocher said कि जो लोकल चैप्टर है एपिकॉन का या IGPP का, APPI का, उसका एक काम है फिजियोलॉजिस्ट का सोशल आउटरीच. सोशल आउटरीच कैसे होगा जब तक वी डोंट डू समथिंग दैट इज रियली टेक अस टू द पीपल. अरे ये लोग हैं, ये करते हैं, ये कर सकते हैं, और इनके पास हम चैलेंज लेके जाएंगे तो ये लोग ये दे कैन डू दिस. Yes, right. So considering that, now this concept of the visualist as an entrepreneur is really important. Like there should be a proportion of people who should be given a path that they can do such kind of activity, and they should be given right hand holding, and they should see the path ahead. Many people think that they can follow this task and they are emotionally charged, but थोड़ा आगे जाते हैं, हॉल के बाहर निकलते, रास्ता ही नहीं दिखता है, कहाँ जाए, where I should go. बहुत सुना, बहुत वेबसाइट्स देखे कि यहाँ जा सकते, वहाँ जा सकते, बट जब काम की बात आती है तो नीचे ओला करे, उबर करे कि ऑटो ले, कहाँ, what I should do, or I should hang on someone's vehicle and then go to reach a destination. So hand holding is very important. So the scope is unlimited. Devices are required everywhere. Input from physiologists are required everywhere. But how we can come out of our shell? How can we equip our with resources? And what are the challenges that we need to discuss? So sir has already shared just this, that the initial product was that, validation did at him. This was another initial product, and miniature product is this watch. This lot you see, it is a modular product now, and it is being used in ICU for non-invasive cardiac output monitoring. This is just one example, I am not saying, but initially, frankly, if you ask me, when Dr. Deepak told me कि आप डिवाइस पे थीसिस करो, वैलिडेशन करो, बहुत लोगों ने पूछा पागल हो गए क्या? डिवाइस पे थीसिस होता है क्या कभी? डिवाइस पे थीसिस क्या करेगा इसमें? व्हाट इज नॉवेल्टी? क्या करेगा तू? And I was packaged with this device when I completed my MD. I was packaged with the device, and technology and human resource transfer was done to L&T. That time I joined L&T myself, and then I came to a Pandora box that what we can do, what is the need of physiologists in the industry, how we all can help, how can we understand the language of engineers, and simultaneously we understand measurement of physiological signals. We say हम बॉडी की फिजियोलॉजी जानते हैं, बॉडी नॉर्मली काम कैसे करता है वो जानते हैं, बट जब तक यू कैन नॉट एक्सप्लेन इट टू समबडी हु इज देयर दैट हाउ टू मेजर इट, एंड द पर्सन हु इज सिटिंग देयर ऑन द अदर साइड, इंजीनियर, ही इज फोकस्ड. किसी को ECG का टास्क दिया है, किसी को SpO2 का टास्क दिया है, किसी को EEG का टास्क दिया है, ही इज फोकस्ड. उसको उतना ही दिखता है, उतना पढ़ लेता है वो. कभी कभी लगता है शायद मुझे इससे कम आता है. क्यों ऐसा फीलिंग क्यों है हमारे अंदर? बिकॉज वी नेवर थॉट इन दैट डायरेक्शन. वी नेवर थॉट टू गो आउट ऑफ द बॉक्स और इक्विप आवर सेल्फ विद द रिसेंट अपडेट्स, रिसेंट नॉलेज in that field, and there where we lack. Now this was another example. I did not do much eureka in this. Even most of the things was done by the engineer who helped me in developing this high altitude hypoxia simulator. So most of, I say 90% work was his. I just contributed 5-10%. But वो confidence वो engineer को देने के लिए एक visualist की जरूरत है. He went to NIMHANS to a very top-notch anesthetist. He went somewhere in south, down south in Kerala, again to some top-notch cardiologist. They said, भाई ये होगा नहीं, ये मत करो. इस पे क्या था? You have to take down the, you have to validate this equipment. The origin of this equipment was very different. That need, what is the need of industry? Need of industry was not to develop the simulator, high altitude hypoxia simulator. Need of the industry was to validate their SpO2 device, जो हमने अभी कोविड में काफ़ी यूज़ किया. उन्होंने खुद ने बनाया, बोले this should be equivalent to the benchmark. बट इसको हम वैलिडेट कैसे करेंगे? तो आई हैव टू जनरेट द रेंज ऑफ हाइपोक्सिया इन हेल्दी इंडिविजुअल्स. Hypoxia starting from 95 to take it to the 70 or 66 in a phase wise manner, and every plateau पे आपको वो सब्जेक्ट का SpO2 सस्टेन करना है. So how can you do this in control environment? तो उन्होंने काफ़ी सर्च किया, इक्विपमेंट बाहर अवेलेबल थे, दे वर वेरी कॉस्टली. ऐसा नहीं कि टेक्नोलॉजी नहीं था, दिस इज नॉट यूरेका माइंड. सो इंडिजिनस नहीं था, और जहाँ गए इंडिया में किसी कोई करने का ये नहीं रख रहा था, कहते हैं जिगर. क्योंकि वाई? दे वर नॉट इडियट्स, दे वर इंटेलिजेंट दैट दिस इज रिस्की स्टफ. Ethics committee will not allow anesthesists. Many anesthesists will say, like even my subject were few anesthesists initially. जो बोलते हैं प्रदीप तू बोल रहा है इसलिए मैं आ गया हूँ, एथिक्स कमेटी ने हाँ बोला इसलिए आ गया हूँ, लेकिन मैं अभी भी डरा हूँ. लेकिन मैंने सुबह एक को फ़ोन किया, वो थोड़ा पढ़ा लिखा बंदा है, न्यूरोलॉजिस्ट है, वो बोला कुछ नहीं होगा. कितने देर कर रहा है? कुछ नहीं होगा. मैंने कैसे कन्विंस किया एथिक्स कमेटी को? SpO2 डिसोसिएशन को पढ़ाया मैंने आधा घंटा उनको, कि इतने मोमेंट पे इतने टाइम पे अगर आप रखते हो विथ ऑल प्रिपरेशन. आई एम माई सेल्फ ACLS BLS इंस्ट्रक्टर. एक एनेस्थेसिस्ट को बिठा के रखा था, डिफिब्रिलेटर था, गाड़ी बाहर खड़ी थी. पहले इनिशियल एनालिसिस है, यू हैव टू डू योर होमवर्क नाइसली. उसका ECG, उसका हीमोग्लोबिन ऑल, किसी का लगा तो यूको सब कर लिया, रूल आउट करके विच वॉज इन द पॉपुलेशन, एंड देन वी डिड इट. सो नीड वॉज वैलिडेशन ऑफ SpO2 and the equipment came out. We had to see the opportunity in the situation. Now again, ये ऐसा इक्विपमेंट हो गया, लेकिन मैं कंपनी के पास गया, चलो कुछ करते हैं, इसको बेचो आप मार्केट में. वो बोले सर, हु आर द टेकर्स? कितने बिकेंगे सर? कंपनी को इतना ही समझता है, हम देंगे पैसा, कितने बिकेंगे भाई? सो अगेन देन यू हैव टू क्रिएट मार्केट नीड ऑल्सो. यू डोंट स्टॉप देयर, यू डोंट हैव कंट्रोल देयर, बट दीज आर द प्लेटफॉर्म्स. पांडे जी ने यहाँ भी होस्ट किया, इतने लोग आए. यहाँ पे हमें इंजीनियरिंग वालों को भी बुलाना है, जो इसमें कुछ काम करते हैं उनको भी बुलाना है कि भाई ये डिवाइस मेरे काम का हो सकता है. तो यू हैव टू क्रिएट दैट अवेयरनेस. अलग अलग प्लेटफॉर्म पे उसको आप पुट करोगे, देन ओनली इट विल रीच टू द पीपल. अंटिल अदरवाइज इट रीच टू द पीपल, इट इज नॉट लाइक कस्तूरी ऑफ कस्तूरी मृग. अब मार्केट में जो दिखता है वो बिकता है, कैसा भी हो. तो आपका विजिबिलिटी नहीं होगा, तो लोगों को पता नहीं चलेगा क्या क्या हो सकता है, क्या पोटेंशियल है. तो लोगों को इतना टाइम नहीं है, बिजी है लोग अभी. They don't have time to think too much. Okay, so there such platform should be there. So these are the challenges whatever I have discussed, few things only. So creating awareness is very very important thing. कितना भी छोटा काम करो, पहुंचाओ उसको. Then we have to understand the need of the society, where it is going. And if you Google now, the world is in your mobile. If you Google across, there are many technologies which can be copied. If you can copy and create Me Too model, there it has market. Or you can do innovation with that thing that you can do it in a minimum way. You can do it at a lowest possible cost. Stakeholder integration and motivation. अब ऐसे मोटिवेटर नहीं मिलेंगे तो बहुत मुश्किल था. They made me to believe, Dr. Deepak, they made us to believe that भाई ये हो सकता है तो कर, कुछ नहीं होगा. बोलने दो, बोलने वाले रहेंगे ही लोग. People will always keep on saying something, but आपको पता होना चाहिए आप क्या कर रहे हो. Definitely you have to take input from intelligent people to keep yourself grounded. So integration बहुत जरूरी है. Networking, that is another thing we lack as a physiologist. हमको एक तो superiority complex होता है या inferiority complex होता है. नॉर्मल होना मुश्किल है. We have to be in physiological range. हाँ, मैं इससे बात नहीं करता, कौन है वो, छोड़ उसको, भाई हाथ जोड़ो. मैं इन लोगों को देख के ही सीखा हूँ, ऐसे नहीं कि मुझे अपने आप आया. और दूसरा मेरा रीज़न है सीखने का, आई हैड एक्सपोजर टू इंडस्ट्री. तो इंडस्ट्री एक्सपोजर से काफ़ी चीज़ें वहाँ पे सीखने को मिली. कि सेल्समैन ये भी देखते बोला है, सर इस बार आपने नहीं खरीदा तो मैं रास्ते पे आ जाऊँगा सर, टारगेट पूरा करना है सर. तो सो मेनी थिंग्स आर देयर. सो यू हैव टू लर्न ऑल ट्रेड ऑफ द ट्रिक्स टू मेक इट. फाइनली यू शुड सी सक्सेस. आप ईगो में रह गए, आप वो प्रोडक्ट बना के रह गए, तो देन इट इज़ वेरी डिफिकल्ट. यू हैव टू लर्न व्हाट अदर पीपल आर डूइंग. सो नेटवर्किंग इज वेरी इंपॉर्टेंट. दैट विल help. Know-how and resources. You have to equip yourself and manage and deal the managing resources. And if you have interest in doing something basic that have a future after 25 years, good, you should do that. That is your passion. But you should have something in hand that will give you current, immediate funding, immediate seeding, immediate money, immediate application. So that will make your survival easy. नहीं तो आप लैब में बैठे रहोगे. सर ने बोला 25 years लगे impedance plethysmography को आने के लिए. So I need some product. So you should have everything in your basket as a physiologist also. And you don't need to leave academia for that. And then as a physiologist, we should create this placement and career opportunities. Because बच्चे जब फर्स्ट ईयर में आते हैं, चाहे वो फर्स्ट ईयर के यूजी बच्चे हो या एमबीबीएस के एमडी के बच्चे हो, उनको बोलेगे ये करो फिजियोलॉजी को, इसमें स्कोप है. वो बोलेगा कितने गए सर? अच्छा 5%, 90% क्या करते हैं सर? पढ़ाते हैं. सर ये ठीक है, बाकी सब है हवा है. भाई पहले मुझे सेटल होना है, शादी करनी है, बाल बच्चे हैं, गाड़ी खरीदनी है. जो सक्सेस ज़्यादा चांस कहाँ पे है? जहाँ पे श्योर हो, वो है रूटीन पाथ. सो डाउन ट्रोडन पाथ, अनट्रोडन पाथ जो बोलते हैं, या जो कम लोग ट्रैवल करते हैं, वहाँ प्रोपोर्शन हम बढ़ेगा तो ही बाकी लोग उसको करना चाहेंगे. सो वी हैव टू क्रिएट दिस प्लेसमेंट एंड करियर अपॉर्चुनिटीज. एंड आई डोंट नो हाउ मेनी ऑफ यू नो रियली दिस मेडिकल डिवाइस रेगुलेशन. दिस इज समथिंग इंटरेस्टिंग. इसका रोल अभी ऑन पेपर बहुत अच्छा हो गया है. MDR 2017 which was accepted by European Union, and since last year it is already now the rule, and same will be done by our CDSCO, or it is in the process. So this MDR 2017 क्या बोलता है कि एक कोई इक्विपमेंट है जो ऑलरेडी मार्केट में भी है, उसका मैंने मीटू वर्जन बनाया. समझो कोई फॉरेन की कंपनी है, उनका है, मैंने उसका मीटू वर्जन बनाया. मीटू NS लुक अलाइक. तो आई हैव टू वैलिडेट इट नाउ. पहले क्या होता था, मैं लिटरेचर पे इक्वालेंसी दिखा दूं, ये वो करता है, मेरा भी वो करता है, टिक टिक टिक, रेगुलेटरी आपको एक्सेप्टेंस मिल गया, यू कैन मार्केट दैट डिवाइस. नाउ नॉट, यू हैव टू वैलिडेट इट. इट इज नॉट ओनली एप्लीकेबल टू डिवाइसेस, इट स्टार्टेड विद द ड्रग्स. डाइक्लोफेनाक का क्लिनिकल ट्रायल मैंने किया है लास्ट इंस्टीट्यूट में. डाइक्लोफेनाक सोडियम का, जो अभी हम 15 साल 20 साल से खा रहे हैं, बट किसी ने वो मॉलिक्यूल बनाया. तो दे हैव टू डेवलप लोकल डेटा, फ्रेश डेटा, current data, and same is applicable for the devices. And there is a great role of physiologist. लोग ढूंढ रहे हैं हम ट्रायल कहाँ करें. कंपनियों के पास इंस्टीट्यूट लोग नहीं है, और डेटाबेस देखते हैं, डेटाबेस में कितने फिजियोलॉजिस्ट के नाम है जिन्होंने क्लिनिकल ट्रायल किया. I did one clinical trial, that was that SpO2 trial, and another device trial I did in my institute. तो उसके लिए आपको पहले हिम्मत रखनी पड़ेगी, पहले डर लगेगा थोड़ा सा, क्योंकि we see that is domain of pharmacologists, our friends only. पर डिवाइसेस की बात आती है तो वो लोगों का भी वो एक्सपर्टाइज नहीं है, वो बन जाते हैं सीख के. वो हमारा डोमेन है, हम सिग्नल के साथ खेलते हैं, वो हमारा काम है, वो हम क्यों नहीं कर सकते. बट यू हैव टू प्रोजेक्ट योर सेल्फ. वो डेटाबेस में आपका नाम तो चाहिए ना पहले. लोग आपको ढूंढेंगे कैसे? आप इतने फेमस तो नहीं हो, अमिताभ तो नहीं हो, हम नहीं है, मतलब आप हो सकते हो, तो हम नहीं है, मोस्ट ऑफ अस आर नॉट. सो इन दैट सिनारियो वी हैव टू इंटीग्रेट आवर डेटा इन सच प्लेटफॉर्म्स. एंड दिस मेडिकल डिवाइस रेगुलेशंस, पल्मरी मेडिसिन के डिवाइसेस हो, मतलब थेरेपेटिक्स के हो, इंटरवेंशन रेडियोलॉजी के डिवाइसेस हो, वो इंडिया में अभी आ रहे हैं. नॉट ओनली स्टेंट्स, द इम्प्लांट्स, देन द पल्स जनरेटर जो ब्रेन में हम लगाते हैं, या फिर पेस मेकर्स. ऑल डिवाइसेस नाउ नीड टू हैव द लोकल डेटा. एंड देयर हु कैन डू इट? इट इज अस along with the clinician who can do it. Or independently. I did it independently, but definitely wherever is required, you can do the hand holding. And this last line, this is my last thing. Material Vigilance Program of India. How many people sitting here have this center in your institute? MVPI. How many know that there is such program? इससे इंडस्ट्री बहुत डरती है. फिलिप्स हो, या फिर और कोई जी हो, या फिर और कोई बड़ी कंपनी हो, उनका रेगुलेटरी जो डेटा है अभी एडवर्स इवेंट डेटा. नाउ सो फार वी हैव द एडवर्स इवेंट डेटा, एडवर्स ड्रग रिएक्शन डेटा ऑफ द ड्रग्स ओनली. एंड yeah, sure, I'll just wind up in 30 seconds. So this Material Vigilance Program of India, Physiology Department can lead this and establish this center, and you become known to industry. This is how you can reach to industry. भाई कौन करता है evaluate हमारे adverse event? तो ये सेंटर फार्माकोलॉजी मोस्टली एस्टेब्लिश कर रहा है डिपार्टमेंट, क्योंकि दे आर ऑलरेडी डूइंग फॉर द ड्रग्स. बट एज अ फिजियोलॉजिस्ट वी कैन टेक दिस This is our domain. I established one center at my last college, the first one in the country, or very few. I established in the last college. So you have to look for the opportunities. You have to look for the such avenues where can you do. And with this, I will stop. Thank you all.
For your talk on challenges in device development. I have just one thing to say after hearing your talk. I think challenges brings up opportunities. So I think we should better take up the challenges so that we can get better opportunities. Right. Usually we end up our careers saying that, I never got an opportunity. I think we should end up by saying we never got a challenge. So with this, thank you so much for your talk. Thank you.
Thank you.
Now moving on to the next speaker. The next speaker is Dr. Ashlesh Patil. He is assistant professor at AIMS Nagpur. His area of expertise are motor neuroscience, cognitive neuroscience, computational neuroscience, autonomic function and neurobiology of brain. He has undertaken various research projects in cognitive neurophysiology and have published articles related to the topic. And he will be giving his
I am Dr. Ashlesh Patil, Assistant Professor in Department of Physiology in Nagpur. First of all, I would like to thank the organizing committee of APICON 2021-22 for giving me this opportunity for presenting my research work and research methodology in this symposium. Now you may read this topic that is machine learning, signal processing and data management tools and find it kind of strange that what is this topic doing in a physiology conference. So over my talk you'll understand why. So my talk will be focused under these headings. So first of all, we'll try to understand that solving the research question is the main aim of a physiologist. Physiologists are, were, and will be always multidisciplinary. Then once we have understood the relevance of this topic, we'll go into the details of the topic, the machine learning, which is the future of the science. What are the tools for machine learning? And what is the path for becoming a data scientist? And finally, I'll touch upon to the signal processing tools and also discuss my own research work. So one may ask, why this topic in APICON 2021-22? So to give an example, let us understand the journey of a physiologist. Of course, we joined this field for two or major three functions. One of them is teaching, research, and of course clinical service. Teaching becomes routine. You always have to keep updated in the new teaching techniques. But the core reason why we select physiology is to do research. So basically, when you come to realize the physiologist has a question and basically he or she wants to solve the question. While solving the research question, it is the methodology that is important, and that is how I came upon this path of machine learning and data analysis. To go back into the history, we always like to teach this action potentials, and these are one of the few beginning lectures for an MBBS student. We teach the action potential in great details, telling them what is an resting membrane potential, what is a local potential, depolarizing, repolarizing, hyperpolarizing, all the phases of an action potential. We also tell them it was the Hodgson and Huxley which discovered the action potential. Rather than discovering, they made the mathematical formulation for this in the giant axon of a squid. But if we go into the details of this model, the Hodgkin and Huxley model, it is nothing but the mathematical model of how action potentials in neurons are initiated and propagated. We tend to omit these kind of diagrams from our lectures, not going into the details of the mathematics or the physics involved. But we need to understand that this model is a set of non-linear differential equations. Maybe this is a kind of a bounce ball to you, but the point that I'm making over here is when you are trying to solve a research question, it need not be fixed to the physiology. Sometimes you may have, and always it happens in me, that you have to go and venture into other branches like mathematics, the physics, and that is how I came upon to machine learning and data analysis. So, what is physiology at present? Of course, the basic definition of physiology holds true. It is the study of how the human body works. Yes, it is the first step of medicine. So, we know that physiology is a very broad area, and when you are entering into physiology, you try to select one of the sub branches. Like I selected the neuroscience part of it. So basically, whenever you are trying to solve the research question, there is a need of developing innovative methods to solve them. And many a times, the costly equipments are either not present in the department, or there is a very long procedure for procuring them. In such cases, you need to do in silico experimentation, or that is an experimentation on the computer, and that is where big data analysis comes. So by now you must have understood physiologists were and will always be multidisciplinary. They must know the maths, they must know the physics, they must know the genetic mechanisms, and many more. So nowadays, lots and lots of big data is available on the genes. Not only that, on EEG, on fMRI, and many more. So once we have understood the need, now let us try to understand what is machine learning. Now, traditionally, all of us have used statistical softwares like SPSS or Stata. So what was happening over there, you were giving an explicit computer code to the computer, and that is how it analyzed or processed the data. But now we have understood that physiology and medicine is much more broad and complex. Many times, a fixed formulae cannot describe the whole mechanisms that is happening in the body. That is where machine learning comes. In machine learning, you don't explicitly program the data. Rather, the model itself learns from the examples. So, you take a data, let's say you take a training data, and you give it into the model trains itself, and finally once you're ready with the model, you test the model onto a new data. Depending upon your results, you can modify the model or get more training examples, and this is how machine learning works. So there are two common methods of machine learning. The first method is supervised machine learning. So to give you an example, let's say you have collected EEG data from patients which were diagnosed with schizophrenia and healthy age match controls. Like you always do, you process the EEG data, extract the features, in the sense you extract the power densities from the various frequency bands. Now in machine learning, what you do, you divide the data into two parts, training and testing data. Now the training data with the labels, so you have the features, and those features are labeled either schizophrenia or normal in this case. And you give this data to the algorithm and you train the algorithm. Once you have trained the algorithm, use that algorithm to and apply that algorithm onto the testing data which does not have labels. So basically you are trying to predict the labels. That is how you do supervised machine learning, where the training data already has labels. Now further upon, you can try to test your model on a new data, on a separate data, and you do statistical comparison, like try to find out the accuracy of your model, the sensitivity, the specificity, and even plot the ROC curves. So this is supervised machine learning. Another type of machine learning is unsupervised, where you do not have any predefined outcome, or in other words, you don't supply the labels to the algorithm. So to give an example over here, so you can see this data, which is on the x-axis, you have the size of the cell. On the y-axis is the amount of the marker that is being taken by the cell. So in unsupervised learning, like to take an example of k-means clustering, it tries to identify the pattern of the data, and it identifies that it has basically 3 clusters. So if you have a look at the raw data over here, you'll find that these kind of clusters were not comprehensible to the naked eye, but the machine learning itself could analyze it and finally give you a result that there are basically 3 clusters. So in other terms, you can say in this particular type of example, there are 3 kind of cells. First kind of cells, which are yellow one, which are getting more stained by the marker, irrespective of the size of the cell, and the other one which are stained less by the marker, but there are these 2 categories. One of them which have less size, and other one which have more size. So in unsupervised learning, you let the algorithm decide the labels. So to give examples, or what are the tools of supervised and unsupervised learning, in a supervised machine learning, you can use linear regression or a logistic regression or a neural network. In unsupervised, you already saw k-means clustering. Now, even principal component analysis that you do for each data is an unsupervised machine learning. And you can try to find out a hierarchy or hierarchical cluster. So let us take the first example of linear cluster. All of you must have been done this lot of time, even on an Excel sheet. So it is same. Linear regression is trying to explain the y data depending on the x data. And so there are these data points, and you try to identify this line of regression. So you have the dependent variable y, which is explained by a constant plus the slope times the independent variable. Now in machine learning, what is different is don't you try to find out this beta 0, that is the constant, and beta 1 by training this algorithm. So when you have this algorithm, and when you give the training examples to it, it sequentially modifies the beta 0 and beta 1, finally coming up to a good solution which describes our data the best. So this is an example of only a single variable linear regression, but you can also have multilinear regression where you can use multiple variables.
We should share this recording with you.
Advantage of machine
time
learning.
is important, so I think we can stop here so that other speakers are given justice and equitably. Since we are running short of time, so I'll request Dr. Anita to kindly just come and give her talk.
Good afternoon, everyone. Am I audible?
Yes, ma'am, you are audible. Ma'am, I'll request you to, if you can kindly limit your talk within 10 minutes.
Sure.
Thank you.
So, I would like to thank organizing committee and the chairpersons for giving me the time. I won't be taking much of the time because I don't have any science to show, just idea what we can do as a physiologist. So, I know there was a time when we were teaching, we started with the chymographs and polygraphs, now with the smart amplifiers, now wearable things. So we do have a lot of scope for physiology. As a physiologist, I would like to ask Dr. Pradeep Berde one question. What is the normal range of inferiority complex and superiority complex. So because when I came to industry, I went into inferiority complex. Okay, my colleagues are publishing the papers, and whereas I'm doing this business. But then after time that I realized that I'm in the physiologist only. My students, my mentors, my seniors, everyone, and I am learning every day, learning new techniques around the world and bringing all those techniques to India. And there is a lot of research in physiology and lot of scope, and I can see the work, whatever is going on in this Epicon and the physiologist, all the aims of India, they are doing very good work. So my idea here is when I came to Dr. Pandey and I told that this is my concept, and so he gave us the opportunity to discuss about it. So a few items like we can see. Can get the mic? So the new fields which a physiologist can think of. Yeah. Thank you. Hello. Okay. Hello. Hello, yes. So the new field is neuromarketing. I know Dr. Deepak has written a book on that. So wherever we go, the physiology is the first thing which we should know how the subject is feeling. So we have a virtual reality along with the physiological monitoring, which we were trying to show on our booth also. So nowadays there's so many stores coming up, online shopping is coming up. Which color is attracting the subjects? What are the pictures should be shown to that? And monitoring physiology like EDR and EDA and heart rate, whether it's giving some excitement or a depression. Some colors are very depressive. People don't like it. So neuromarketing is one of the major field where we can enter and do our research. Then the facial expression. There is one new software which measures the facial expression. So, and then along with the facial EMG, we measure the facial EMG and we can get the information whether the subject is smiling or frowning. From that, we can get the information of the mood. So that's how, like another thing which is new added in the physiology research and can be done. Then eye tracking, where the subject is looking, performing any kind of manure, like for nutrition, Dr. Kochar has done a lot of work, ma'am has done a lot of work with eye tracking and the nutrition. People are looking at the foods and you know that you are from that field, that how eye tracking can be useful. The eye tracking can be useful while driving or other subjects. Then sports. Sports physiology is picking up a lot. Wearable sensors during our team, how we can monitor their HRV and other physiological parameters. So I want, no. These are the few companies internationally which we are promoting their products. So I won't go into the detail, but then we have wireless systems from Equivital, which is waterproof. So while swimming also you can monitor at high altitude ECG respiration. And from Biopac also, Biopac, most of the people are using it here for wireless monitoring. A number of parameters together can be monitored during any kind of scenario. Then recently we have added few European companies, biosignal plugs. So biosignal plugs, I will be showing how it looks. It's from Portugal. It's a small kit and it's very budget friendly. So, I mean, one for the cost of Biopac. I'm not saying that we should not buy Biopac, but how to choose the right equipment for the right place. Then NeuroCode for the softwares. Like autonomic nervous system can be assessed using the software, baroreflex sensitivity and HRV software. And so this is another field which we need to talk to our IIT people, and definitely sir has already worked a lot on HRV software. how we can integrate our system with the Indian softwares. So now we are at a stage that we have to promote Make in India. We have to promote, now we have imported so many things. Now we want to make a transition, something, collaborations with the companies abroad and in India. So these are the products for animal research. Yes, they are used for physiology and pharmacology. They also have lot of prospect for animal monitoring in pharmaceutical companies. There is a lot of requirement for the ventilated cages and behavior softwares. So the first company which we started, BioPack, is used by 97% of the university across the world. And the main, why we like BioPack personally, because it has a system right from teaching to research, eye tracking, cerebral hemodynamics, all on a same platform. And it gives an option to make own softwares. So what they did during pandemic is they made this one channel data acquisition system. We can monitor 5 parameters and they send to their students at their home. And the software can be downloaded, it's a free of cost. So I would suggest if someone can help us making this kind of software in India, like the pandemic is, we are not sure about how to go about it. We have a scripting option, or we can collaborate with the IITs to write lessons according to the curriculum in according to the ICMR, so that we don't have to depend on only on the BioPack. This is very simple. I think we can talk to some manufacturing and industry, which we are already talking about for manufacturing the hardware. But definitely without the collaboration with the medical doctors, physiologists, it won't be possible for us to go ahead on it. This is one thing. These are the routine 2-channel and 4-channel data acquisition for teaching for all sort of physiological parameters. The package is according to the curriculum, physiology, biochem, or like pharmacology, health sciences. So the package comes and you can start teaching the students. Then the research version, we have 4 to 16 channel. So 16 channel, the parameters, the list of parameters is huge, both wired and wireless. Non-invasive cardiac output, we can do SpO2 and non-invasive beat to beat. So all the physiological parameters can be monitored using 16 channel data acquisition system. And the same system can record the wireless parameters at a time. Suppose you have some wired parameters, and then the subject goes into the field with the logger, a smart center. It comes in a briefcase, you take it to the field. People do research in mines at high altitude or something, any scenario where they want to carry, and they can monitor 9 parameters at a time and come back and transfer the data into your system. And life monitor, as I told, it's from UK. So choice of your interest, cardiovascular or neurophysiology, you can choose the transmitters. And so this gives us the experience, the freedom of discovery. Like, we need not to be in the lab only to perform physiology research. We can go anywhere and do our research work. So this is how the data appears. This is the biosignal plugs. It's from Portugal. It has very small data acquisition. This is 8 channel, less than the size of a phone, and the price is also less. It works on a Bluetooth technology. Few IITs have started using it because it's very economic. So, and they do have some kits for teaching engineering students, for making biomedical kits. So recently we started this year only importing that also. So to encourage engineers to make biomedical equipments in India. So that is another thing which is a new addition with us. Then is the lifestyle assessment. It can be done, there are different kinds of wireless shirts, wearable shirts, And then the lower one, which you are showing, these are the bands. These are usually used for the sports team. So you can monitor their HRV continuously and analyze the HRV, heart rate, respiration, and it gives the reports in the form of stress. But this is not still allowed in India. So for that, again, we need a software engineer that how to tell that autonomic balance is there or not, if HRV is in this range, if baroreflex is in that range. So generating a report, we can sell this very easily. Oh, this is giving heart rate and ECG. But for the sports person or other wellness center, they don't know how to interpret it. For that, we need a software. So again, this is again a area where we can work and we can collaborate. Then eye tracking. Eye tracking is you can wear it on your glasses also, and where the subject is looking, you can monitor that. It's comfortable, lightweight. And then this is showing the person is driving and his physiology is being monitored. He's wearing eyeglasses. We can see whether he's looking at the rear view mirror or not, or he's looking right or left properly. This is being used for like giving license also by the driving schools. So all these things have lot of importance to make a physiology research very important. So then we have an eye track bar. This is not that because some don't feel comfortable wearing the glasses. This is kept in front of a PC, and the similar function gauge path, gauge plot, heat map, attention map can be recorded using eye tracking bar. Then when we come to neurophysiology, with cerebral hemodynamics, again Madam is doing a lot of work on that. And FNIR is also wireless. Subject can wear and can go to the field, and it can measure the muscle oxygenation as well. Like if you want to measure for the fatigue of subject, it can be used there. Then virtual reality. Virtual reality, we don't feel like importing the Oculus from somewhere and such expensive thing, but we can create the softwares.
No, ma'am, I just wanted to add on to what Dr. Anita is saying, that if it is made for monitoring car driving, we can monitor it for motor planning and execution. So to scale it to neurophysiology, something which is purely for market, then one device does one thing, we can combine the devices and give a whole set of endophenotypic or physiological markers. So that is what we are doing, and that is why we need to join hands. Ma'am, if you don't mind, we are really short of time. Inka tea break bhi encroach ho gaya. So it is my pleasant duty to invite Professor Ashok Jaryal. He will speak his own experience on this path, and he will also wind up the session. And we are always available to interact with you. Today is the beginning, and we'll always be in touch. Thank you.
This is, I think, one of our departures that we had from the previous Epicons, that we could bring in the industry on the similar platform. So Professor Pandey, thank you very much for starting this kind of trend for us as a physiologist, and also the industry to support our events, because that's partly also important, because we got to eat and live, and somebody has to foot the bill. So that way the industry is recognized. Madam, thank you, Madam. Dr. Anita, for supporting the Epicon. We had a fantastic session where we had 3-4 decades of history, personal experiences, success stories. I think that motivates us. That, okay, if somebody, when somebody says America has landed on moon, we just believe it. But when you say this paint is wet, we touch it. That's the human nature. So when we see people amongst us succeeding, it gives a motivation that I can also do. And that's why these kind of gatherings are important, to see success stories amongst us. we listen to things like, one phrase which I took a very long time to understand was out of box thinking. And I thought, okay, well, how do I start thinking out of the box? Everybody says think out of the box, but how do I train myself to think out of the box? I would say it took me 20, 30 years to understand that the box was my own making. A child doesn't have a box. Child thinks freely. Perhaps our own constraints, our own understanding of what I can think is the box. So, and this boxing has occurred primarily for sake of efficiency in industry, after industrialization. Fast making, fast prototype, everybody similar. That created a box rather than, there was no box. There was actually never a box. So out of the box thinking in some ways a antagonistic joinage of terms. We also heard, if you were in charge of innovation lab, what would you do? I mean, telling somebody, like bat well, it doesn't actually translate into action. So we remember Azharuddin's famous interview. He was asked, what will India do in the next test match or cricket? He says, we'll play well, bat well, bowl well, we'll win. Okay. I mean, that of course makes sense. But then the question, I guess, how do you make somebody bat well? Those processes, and that's where I think all of us need to understand that creating an environment is critical. And increasingly, all of us are getting trapped in excessive consumer behavior. It is said in psychology, boredom is necessary for creativity. If you are always engaged, you are spread thin, you do not have time to think, because we are just running. So, and also we need to limit our, you hear industry success, idea success, product success, and we are motivated to do everything. Maybe I should become industrial entrepreneur like Madam, or Dr. Deepak, idea entrepreneur, or Pradeep, product entrepreneur. मैं कौन सा choose करूं? Or there could be others. Dr. Malik is not here. Pure science entrepreneur, finding ideas, and he's happy there. We need to find our own zone of happiness, emulate the process. There are people. So before Edmund Hillary reached the top of Mount Everest, a person died doing that in third attempt. In the second attempt, he came down. He has lost his toes, foot, everything. They ask, why do you go there? What are you doing? He says, because it's there. That was his answer. Because it's there. So there are many of us who behave in that manner. कुछ है आगे तो कर लेते हैं. And child does in that particular manner. There is no return. There is no फल की चिंता. There is no fall, just have to do it. There are people like that. There are people like Elon Musk's who look at the societal needs, find a money for themselves. That's also fantastic. We need not compare each other. You find your own branch on the tree or the roots wherever you are. And humbleness, I think, is the key for creating an environment of innovation. We have poster presentations here. Every poster presentation is as good as a Nobel laureate's work to me, because somebody has done something. We need to look at that positive support to each other. Then innovation will occur. That's a natural course of life. I mean, we have evolved from nothing. The nature has own ways of innovation. Mutations are innovations. Some succeed, some don't. But steps are taken. And to us, we have to recognize that around us, no matter how small work we are doing, that is innovation. And some may manifest in terms of material values, some may manifest in spiritual values, some may just manifest for happiness itself. Why not? With this, thank you, Professor Kocher, for organizing such an event that brought different aspects of entrepreneurship to all of us. Thank you, madam. Thank you, madam, for chairing this session. And Dr. Lakshmi, I think she's online. Thank you, madam, for being with us from Bangalore.
Thank you all the speakers. This was indeed a very lucid talk, and as discussed with Dr. Deepak, not just physiologists, we all as doctors or medicos, we need to think out of the box and become entrepreneurs and maybe become something which we have the potential or but we don't realize. I again thank you all the speakers for the wonderful talk. I now request Dr. Parmar to please come on the stage to felicitate the speakers. Acha, I request all the speakers and the chairpersons to please come on the stage. A big round of applause, ma'am. Dr. Pradeep. Dr. Anita Talwar. Dr. Ashok Kumar Jhargal. Jhargal, sorry sir. Thank you, sir.
Yeah, good afternoon, everyone. It was a wonderful academic feast. Though it was actually, I am really grateful to BioPack, Dr. Anita Talwar, Sandeep ji for a financial assistant for the APCON 2021. And actually, it was not a sponsored symposium because it was better than any symposium. And just I was discussing with Dr. K.K. Deepak that we can have a similar symposium on some other occasion so that more and more physiology pharmacologists may attend this one. Yeah, thank you very much.
Your pendant? Harish Gupta. Next we have with us Dr. Harish Gupta Awards. The announcement for the same will be made in just few minutes. Good afternoon, everyone. Now we will begin with the Harish Gupta Prize. The judges for the same will be Dr. H.N. Malik, who is the Professor of Physiology, Faculty of Medicine and Health Sciences at SGT University, Gurugram. He is the former Professor, Department of Physiology at AIIMS, New Delhi. His research interests are importance of sleep in health and diseases, neural mechanism of sleep, as well as neural mechanism of temperature regulation. He is the President of Indian Society of Sleep Research and Asian Sleep Research Society. Also, we have Dr. Divya Srivastava, who is the Professor and Head Physiology at SN Medical College, Agra. She is a teacher and researcher by passion. I welcome both of you, sir and ma'am, to please come forward and take the seats. ठीक है, sir. I will request the judges to please start the session. मुझे बोलना है? अच्छा, पहला कौन कर रहा है? अच्छा. I will request Dr. Arjun, who is MBBS student from ASIC Medical College and Hospital, Chennai. His topic of presentation is knowledge, attitude and practices of second year MBBS students regarding the use of face masks to limit the spread of new coronavirus disease. You have 10 minutes, 8 minutes for the presentation and 2 minutes for the question answers. All the best.
A very good afternoon to one all present here. Now this is a KAP study. This was a KAP study conducted in our hospital at the outbreak of the second wave. The advent of the COVID-19 pandemic advocated strict hygiene practices, including face mask use. Now, the medical community wasn't new to face mask use, but the COVID pandemic necessitated it in such a way that we needed to look at how medical practitioners use face masks. Now, face masks, simply put, work by preventing the spread of diseases through droplets. So, there's a barrier layer in face masks that prevent the spread of infection through droplets and in many cases aerosols. Now, the principle here is that the pores of the mask have to be larger than the aerosols, smaller than the aerosols themselves. Otherwise, they will cross. So, that's a simple principle. Now, masks have been proven to be effective. Many studies have proven that masks are indeed effective, and there's an increase in public interest in mask use. However, improper use increases the spread of diseases and in many ways reduces the effectiveness of masks. Now, studies done before the pandemic have indicated some amount of inadequacy in the way healthcare workers handle masks. Now, confidence in mask use doesn't always translate to outcomes. This is another result of studies. So, healthcare workers who are confident in mask use weren't necessarily adept in the way they used masks. Now, poor compliance was brought from problems during mask use. Now, it's necessary to characterize these inadequacies and problems in order to design programs to prevent problems during mask use. Now, the aims and objectives of the study are to investigate the knowledge, attitude and practices of second year MBBS students with regards to face mask use in a tertiary care hospital during the period between July 2021. A structured questionnaire based on previous studies was generated. This was pilot tested and verified. It was verified by professors of pharmacology and a professor of community medicine, and it was pilot tested by students belonging to the third year. And then ethical committee approval was obtained, and 102 students belonging to the second year, 5th semester were mailed the questionnaire. The questionnaire had 14 questions. There were three sections. The first one regarding knowledge, the second one regarding attitude and practices, third one regarding problems during mask use. The participants were anonymous and data was stored anonymously. All consented. Now, this is a 100% response rate. Now, these are our observations. You can see that 97% of students felt that wearing a surgical mask was good. Most of them realized that that wearing the white side in is essential. Most of them were also able to identify there are 3 layers. And then now this result is disturbing. Only 33% of students knew that a face mask can be used for up to 8 hours as a stretch. Now, most students knew which layer acts as a filter media barrier. They knew that the purpose of the metal strip was to fit on the nose. And this is again disturbing. Most of them thought that cloth masks were as effective as facial masks. It's completely untrue. And again, they knew that the mask had to cover the face, mouth, and chin. Now, practical and attitudes. Now, most students did not remove, all students in fact did not remove their masks during clinical sessions. They stored their masks in a bag for future use. Now, this is sad. Most of them wore masks in public. Now, this is good because an avenue for healthcare workers to get infected is outside their hospitals. Now, many of them knew that the yellow bag should be used, but quite a few of them did not. Now, again, this is sad. Many of them felt they were confident. Now, this is good, but again, confidence doesn't always translate into attitudes. Now, this is problems that they encountered during mask use. Now this study is an outlier in that many studies did not show participants having many problems. Now, only 24% of our participants did not have any problems. Many of them had headaches, facial sores, but the most important problems they faced were breathing difficulties. Now, we attribute this to be because mask use was throughout during the pandemic as opposed to during individual sessions before, and that it was imposed. Now, our conclusion, participants had good knowledge, and with 80% of them selecting the correct option in over 6 of the 8 questions, 90% of them felt that cloth masks were as effective as surgical masks. Now, this is sad. Now, Singh et al., which is a study, attributed this to internet sources, which was spreading during the pandemic, saying that we can wear cloth masks. Now, only 32% of students thought that surgical masks can be worn at 8 hours for a stretch. Now, this can lead to increased costs and biomedical waste generation. With regards to practices and attitudes, they were generally good, but there was some scope for improvement. 90% of participants answered 3 out of the 5 questions correctly. 90% of participants stored their masks in a bag for later use. Now, this is bad. Only 77% of respondents knew the correct color-coded bag. Now, again, there is some scope for improvement here. Only 24% faced no problems. Now, the low number may be due to healthcare and pandemic. That is the low number of people who face no problems. And then age is associated with compliance to mask use. So, very often problems faced during mask use lead to decreased compliance, but we need to account for the fact that elderly people are more likely to be compliant despite problems as opposed to younger people. Now, future research and directions, data should be collected from other batches from our hospital as well as other hospitals to compare and collate. Training programs on PPE usage should be conducted, and people should be oriented towards the practical aspect of mask use, because knowledge was good, but practices and attitudes are moderate. There is some scope for improvement. There should be additional research design to ensure comfortable surgical masks. Now, these are our references. Thank you.
In which year are you at present?
Ma'am, I'm currently a third-year student.
Currently third-year student. Okay. Why did you decide to do this topic?
Ma'am, to begin with, mask use is something that we always picturize doctors doing. But at the same time, at least during the course of my first year, I realized that we had very little exposure to mask use besides in the foundation program. And then during the onset of the pandemic, I realized that mask use was trusted upon me, not only as a medical student, but also as a citizen of the country. So I wanted to understand how we look at masks and how their effectiveness changes, because there was a lot of information across platforms, YouTube, Twitter, and then again the newspapers, and again what people told me from my own family, from people I interacted with. So in midst of all this conflation, I wanted some clarity.
So you found some knowledge gap. So was it addressed at the end of the study, the knowledge gap?
Ma'am, when we collected data, we did instruct them on the color-coded bag that they must use. We also instructed them on where they should dispose the masks, ma'am, and that they shouldn't carry the masks with them after use.
There were a lot of knowledge gaps, na? We saw.
Yes, ma'am.
So,
Yes, sir. The departments in our hospital do have various color-coded bags. Yes, sir. Sir, college reopened for a small period between the first wave and the second wave. So the color-coded bags that we are talking about are primarily during what they did in that period, sir. Sir, there is a lot of available literature on the utility of masks, sir. Sir, the novelty is that this was conducted during the pandemic in a very specific environment, sir. This is an environment where this has not been explored previously because before the pandemic, mask use was restricted to certain areas. Now, mask use was prevalent across both hospital and out of hospital settings. There's a lot of misinformation coming from the internet, which was not there in previous times.
yes, if the audience would like to ask anything, the house is open for questions. Yes, if our online audience wants to ask, the online delegates, you can unmute yourself and ask the question.
Any questions? Thank you. Thank you, Dr. Arjun.
Thank you, sir.
Next presenter is Dr. Shivani Chaurasia, who is also MBBS student from HIMSS Barabanki. Her topic is effect of internet addiction on sleep pattern and cognitive functions among young adults. You have 8 plus 2 minutes. You can start. All the best.
Thank you, ma'am. Good afternoon, everyone. Ma'am, sorry, sir. Sir, third year student. Good afternoon, everyone. My name is Shivani Chaurasia. I am an MBBS student from HIMSS Barabanki. The title of my research was Effect of Internet Addiction on Sleep Pattern and Cognitive Functions Among Young Adults. Internet addiction is an emerging social and mental health issue among the youth across the world. Individuals with internet addiction show loss of self-control and recurring maladaptive internet use. This condition has negative consequences and it also causes significant psychological distress. The potential relationship between internet addiction and certain cognitive problems has been suggested by several studies. As the smartphone technology is getting more and more integrated with everyday life, use of internet addiction before sleep is becoming a habit in young adults. This behavior has the potential to prolong sleep latency, resulting in reduced sleep duration. It is eminent to investigate the various cognitive as well as neurological aspects of internet addiction as a model of addictive behavior. Advances in broader area of internet addiction will facilitate the understanding of the cause, mechanism, and effect of this behavioral addiction. The primary objective of my research was to evaluate the correlation, the effect of internet addiction on sleep pattern and cognitive functions among young adults. Secondary objective, to study the effect of internet addiction on sleep pattern and cognitive functions among young adults. The methodology I used was, there were 30 apparently healthy young adults of age group 18 to 35-year-olds randomly selected from community. After examining, the participant will asked to respond the questionnaire based on internet addiction test, Pittsburgh Sleep Quality Index, and trail making test. Statistical analysis followed by the discussion and conclusion. For the observation, we use different study parameters of the participant. The parameter we used are age, internet addiction test, subjective sleep quality, sleep latency, sleep duration, habitual sleep efficiency, and step disturbance, sleeping medication score, daytime dysfunction score, global PSQI, and trail making test part A and trail making test part B. And the observation are shown to all of you. These graphs show the correlation of internet addiction test and global PSQI. And we found the positive correlation between, there is significant correlation between the internet addiction test and global PSQI. This graph shows the correlation between the internet addiction test and trail making test part A, and this graph shows the correlation between internet addiction test and trail making test part B. As for the result, in our study, a significant statistical correlation was found between sleep quality and internet addiction. The positive correlation between poor sleep quality and cognitive functions was also seen. In this study, we didn't find any correlation between internet addiction and cognitive function. Conclusion, despite the various limitations, this study has provided some important information about internet addiction among medical students and their pattern of sleep. There is significant relationship between internet addiction and health. Poor quality of sleep can lead to untoward consequences in students. It was found that students have poor control over their internet use, which may indirectly affect their difficulty in establishing concentration, low academic output, increased dependency, and behavioral change, which overall affect their performance in academic as well as daily life. The future research and direction were several treatment options have been investigated for internet addiction, including different pharmacological and non-pharmacological that showed some effectiveness in symptom reduction and craving control. However, it required a good clinical experience-based and research-based evidences to reach a conclusive option to get rid of this silent pandemic. I acknowledge Department of Physiology, HIMSS Barabanki, and the student who are participating in the study, and ICMR for the approval of this research topic. And these were the references, and thank you everyone.
Very nice paper, Shivani.
Thank you.
Very good, I would say. The topic is really interesting, and it is a very big problem these days, that is internet addiction in students and in children also. Even in young children, I see 3-4 year olds, they are also hooked to the computers and the laptops. Okay, so this is a good problem that you have addressed. So I want to know who were the students on whom this research was done? कौन से आपके subjects कौन थे?
Ma'am, medical students.
Medical students?
Yes, ma'am.
And they were at home because the pandemic was going on and online classes were there.
Ma'am, the research proposal was accepted before the pandemic, but we collect the data after the first wave के बाद वो reopen हुए थे.
How was the data collected?
मैम क्वेश्चनेयर्स थे इंटरनेट एडिक्शन टेस्ट के लिए थे, जो कि डेवलप डॉक्टर किम्बरले यंग के वो किए थे डेवलप. तो उसमें 20 क्वेश्चंस थे. वो मैम एक अलग से एग्जामिनेशन रूम था जिसमें एक अटेंडेंट भी साथ में थे, और ये सारे हम लोग पहले जो पार्टिसिपेंट थे उनसे कंसेंट फॉर्म मैम साइन करवाए. फिर उसके बाद उन लोगों से वो लोग सेल्फ ही मतलब मैम वहीं पे करवाए.
Study was done when the students came back to
Yes,
the college.
ma'am. Yes, ma'am.
What are the limitations of the study?
Ma'am, time duration, as we only get 2 months for this research. मैम ये ICMR STS प्रोजेक्ट के अंडर ये रिसर्च किया था मैंने, तो इसके लिए ड्यूरेशन मैम 2 मंथ्स ही मिले थे हम लोग. यस सर. यस सर. Sir, during day. Yes, sir. No, sir. Sir, in the questionnaire given to them. Yes, sir. एक्चुअली सर हैबिचुअल तो ये लॉकडाउन की वजह से सर मैक्सिमम यस सर यस सर सर क्वेश्चनियर में जो क्वेश्चंस थे उसमें ऐसे क्वेश्चंस थे कि यस सर यस सर यस सर मैक्सिमम जनरल पॉपुलेशन के पास मोबाइल फ़ोन्स यस सर मोबाइल फ़ोन सर मोबाइल फ़ोन यस सर मोबाइल फ़ोन एक्चुअली यस सर सर it increases the sleep latency sir yes sir I heard yes sir yes sir and trail making yes sir सर एक्चुअली डेटा मैंने कलेक्ट किया था लेकिन ये जो ग्राफ वाले चीज़ें थे ये मेरे गाइड ने हेल्प मतलब गाइड ने ही की थी एक्चुअली सर मोस्टली 4 to 5 आवर थे यस सर yes sir yes sir thank you sir
Thank you, Dr. Shivani. The next presenter is Dr. Shreyasi Seth, who is MBBS intern from School of Medicine, Sciences and Research, Greater Noida. Her topic is parent-directed use of over-the-counter drugs and alternative medicines among Indian pediatric patients. You can start.
Good afternoon, respected judges, distinguished faculty members, and fellow students. Today I, Shreyasi Seth, stand before you to present our research, Parent-Directed Use of Over-the-Counter Drugs and Alternative Medicines Among Indian Pediatric Patients. Use of over-the-counter drugs and complementary alternative medicines, including traditional home remedies, as initial options for treatment by parents has been used worldwide since many years. Parent-directed medication is a double-edged sword with its own advantages and disadvantages. Most minor ailments can be treated without any serious concern. However, the pediatric pharmacokinetics and pharmacodynamics are very different from adults. parent-guided medication for the pediatric age group by empirically extrapolating the adult dosages can sometimes result in therapeutic failures, adverse effects, and even fatal outcomes. The aims of this study were to evaluate the prevalence of parent-directed medication in pediatric population and to explore the attitude, perception, and determinants of parent-directed medication among parents of Indian pediatric patients. This was an observational, descriptive, cross-sectional, questionnaire-based study conducted during May and November 2021 in the Department of Pharmacology in collaboration with the Department of Pediatrics at a tertiary care facility in Greater Noida. This included parents of pediatric patients who visited the pediatrics department of the hospital after taking voluntary and written informed consent. Data was collected as face-to-face interview-based survey administered on a semi-structured questionnaire to parents. Questionnaire was prepared after consultation with experienced faculty and prior approval was taken from the Institutional Ethics Committee. The sample size was 284 and data collected was evaluated and interpreted after appropriate statistical analysis for descriptive studies. We observed that out of a total of 284 respondents who were asked if they had given any medicines without prescription or any alternative treatment to their children for any disease without consulting or without approval of a registered medical practitioner, out of these 284, 182, that is 64%, admitted to have practiced the same. We also observed that in our study, respondents were both fathers and mothers. That is, 1/3 of the respondents were fathers and 2/3 were mothers, and we found that the prevalence was common in both kinds of parents. Significant statistical difference was noted in the prevalence of parent-directed medication in parents with a single child versus parents with 2 or more children. We can imply from this that parents with 2 or more children are more experienced or more familiar with medications that they have given to the previous child. Hence, they are more confident and hence the prevalence found could be more. The study was conducted in a urban setup which is surrounded by many villages in the periphery. Hence, our respondents belong to both rural and urban areas. And the prevalence was present in both the categories. Toby et al. And other Danish studies had found that there's also a link of educational qualification, and well-educated mothers were more prone to give OTC drugs to their child without prescription or any other therapy without prescription. However, no such correlation was found in our study, and it was common in all kinds of educationally qualified parents. It was also found common to be in both nuclear and joint or 3-generation families. The reasons could vary, which we'll be seeing later. Significant statistical difference was also noted in parents belonging to upper class with respect to middle class. That is, parents belonging to upper class were more used to giving parent-directed medication, that is 75%, with respect to middle class, that is 54%. The types of treatment given by the parent varied. However, OTC or conventional allopathic medication without doctor's prescription was the most common type, followed by other CAM therapies. Among alternative medical systems, homeopathy ranked the highest. As we can see, prevalence of PDM was common in all different age groups of children. The most common indication of giving PDM, parent-directed medication, was fever and URTI, and the most common route was oral. This is similar to other studies that have been found in other countries. The reasons varied again, and time constraint as first-line management of child's emergent symptoms was the most common reason of parents giving medications on their own, followed by other reasons like nearest doctor being far away from home, or their treatment had proven effective in the past, or as we had found more in joint or 3-generational families, the influence of grandparents and peer parents. The next set of questions were posed to know the attitude and perception of parents regarding the same. The most common source of information was previous prescription by a doctor. Majority of the parents believe that it has been effective in all diseases of their child. It has even been better in many cases than the treatment advised by the doctor. Very few believe that the treatment could be harmful, and 72% were confident about their treatment. And half of them recommended their treatment to other parents also, and 1/3 parents agreed that they would continue to use PDM in the future as well. Majority of the parents said that proper medical knowledge is necessary to administer medicines to a child. Adult and pediatric dosages vary, and they can have interactions. This despite the high prevalence. 72% said that the doctor does ask them about any medication that they had given the child before consulting the doctor. Yes, ma'am. Right, ma'am. Majority also said that they informed the doctor about the treatment given. The widespread prevalence of self-medicating practices require the need for educational and therapeutic programs. We need to have a balanced, practical and judicious approach to do what is in the ultimate best interest of the child. These were the limitations. This study was awarded the STS, Indian Council of Medical Research Scholarship. Yes, sir. We conclude from this study that statistically 64% of the parents practiced parent-directed medication. Significant difference was noted in prevalence among parents with more than 2 children versus those with a single child, and significant difference was also noted in prevalence among upper and middle classes. The study was awarded the STS ICMR scholarship. These are the references. Yes, ma'am. Ma'am, the limitations were that even though the sample size collected was as diverse as possible, India is a diverse country and similar findings can be found in other studies. However, this was conducted after all in a small geographical area. And ma'am, representation from illiterate and lower income groups was lesser in our study. And also that parent-directed medication is a vastly branching domain, and this study only opens avenues for separate studies focusing on different groups like adolescents. These are the questionnaires. Yes, ma'am.
So, very well presented.
Thank you, ma'am. Thank you.
Very good study.
Thank you.
And congratulations, you got the scholarship.
Thank you, ma'am.
So, my question is that you've talked about a questionnaire.
Yes, ma'am.
But was it validated?
Ma'am, it was presented before experienced faculty members from pediatrics and pharmacology. Yes, ma'am.
And what was the age of the pediatric population?
Yes, ma'am. Ma'am, we included anyone below the age of 18. So I have a graph for this.
So that is also very wide range.
Yes, ma'am. It is. Yes, ma'am. Yes, ma'am. Yes, ma'am. So as I said, this was one of the limitations of my study, that we couldn't establish it, even though we could tell in which age groups it was prevalent, and it was prevalent in all age groups. Separate studies can be conducted in adolescent populations separately, because I had noted that in case while I was interviewing the parents, adolescents themselves influenced what the parent was giving to them. So that comes under a separate category, and that's about it, ma'am.
Nowadays, there is a big generation of the Google, trained people who comes to the doctor.
Yes,
So
ma'am.
this applies to anyone who comes, because everybody is doing the same.
Yes, ma'am.
How do you plan to address this issue? Taking a step, what is the way forward to it?
Ma'am, firstly, ma'am, we need to ensure that in the pediatric OPDs, we are not an abhorrent attitude towards anything that a parent gives to a child can also prove to be futile, because the parent might not accept it in a positive sense. So it has to be a balanced and judicious and practical approach in which the parents, the pharmacist and the doctor have to collaborate and do what is in the best interest of the child after foregoing all their biases of what is right and what is wrong.
Various level steps can be taken.
Yes, ma'am, right.
Mostly you are reading the slides I saw in the initial part.
Yes.
And you did mention also homeopathy.
Yes, sir.
So the parents were able to prescribe homeopathic drugs?
Sir, right. Thank you for your question, sir. Sir, homeopathy, what I had noted most commonly was that peer parents had mentioned a specific homeopathic drug for some specific symptom or specific ailment. And then they had. Yes, sir. Yes, sir. That is true. I understand what you're saying. The sugar pills have to be prescribed by a CAM specialist. However, in this we had also included. Yes, sir. Right. Yes, sir. So this also included other homeopathic brands that are available at chemist shops. The science? Sir, this study tells us on the prevalence of the practice, and since no scientific studies are available in a country like India where CAM is so prevalent and traditional home remedies are given in every other household. Right, sir. So I'm an intern. Yes, sir. Right, sir. Right, sir. Sir, so the pharmacodynamics and the pharmacokinetics and the drug dosages are very different between the pediatric population and the adult population. And extrapolation of the same can lead to severe adverse effects. Yes. Yes, sir. Right. Yes, sir. I have tried to mention it. Uh, so I had to skip a few slides because of time constraint. Yes, sir. Right, sir. I understand. Yes, sir. Thank you, sir.
That was a beautiful presentation. Thank you, Dr. Shreyashi. Next, we have Dr. Rahul, who is MBBS student from our own college, ASIC MCH Faridabad. His topic is to correlate the level of stress using galvanic skin response with the perceived stress scale in the Indian medical student.
Good afternoon all. Myself Rahul, and today I am here to present my study to correlate the level of stress using galvanic skin response with a perceived stress scale score in Indian medical students. Stress. Stress is a feeling of emotional strain and pressure. Mild form of stress may be beneficial in learning, but excessive amount of stress may lead to psychological as well as physiological impact on us. It may lead to strokes, heart attack, depression, anxiety, and many other problems. A large number of population have this stress, with a prevalence of 27% to 37% all over the world. The aim was to assess perceived stress level. On the basis of the perception of stress level, I categorized the students into vulnerable, semi-vulnerable, and the non-vulnerable groups. It was objectively examined users' emotional arousal level by utilizing GSR. It is a cross-sectional study which acquired 54 first-year MBBS students aged between 18 to 25 irrespective of their genders. The inclusion criteria in my study were healthy first-year MBBS student aged between 18 to 25 with a normal hearing abilities. The exclusion criteria in my study were any student with a history of any chronic medical illness, neurological disorders, and history of any psychiatric illness, or student on psychotropic drug use, or student with a hearing impairment. Galvanic skin response. Galvanic skin response is an electrical resistance measured by passing feeble electric current between two electrodes placed on the hand of a non-dominant hand. The instrument that is used for galvanic skin response is AD instrument, that is GSR amplifier. Here, we use the two 8 mm diameter reusable electrode attached to the middle phalanx of both index and the middle finger of non-dominant hand. Total time recording is 1.5 minutes. Sampling rate of GSR is 1000 Hertz. And then the data is analyzed by the MATLAB software that is sectioned into the 30 seconds each. The peak latency of GSR has been calculated. Here, the unpleasant auditory cue has been introduced with the help of the earphones. Perceived stress scale. Perceived stress scale refers to the stress that is perceived by any individual. This is first introduced by Cohen, who showed the correlation of PSS with multiple other parameters, such as stress measure, self-reported health measures, and the health-seeking behaviors. On the basis of the perceived stress scale, we classify the student into Group A, Group B, and Group C. That means non-vulnerable group, semi-vulnerable group, or the vulnerable groups. Data collection and analysis. Data collection using API Info version 7. Chi-square test was used for significant the categorical values, whereas ANOVA test is used for difference between continuous variables. The total number of participants in the study were 54, who were divided into 3 groups based on the PSS score. Overall, the PSS score was 15.83 plus minus 5.62. We found that the score in the group C was significantly higher as compared to mild and the moderate level of groups. GSR response of study participant. In this, we show that the group A show GSR latency of 36.23, whereas group B show 38.32, and the group C refer to 28.00. This signifies that ANOVA test value is p-value greater than 0.00 is not significant, and no significant correlation was seen between PSS score and the GSR latency as well. The conclusion of my study showed that majority of students was found to be moderately stressed, approx 63%, whereas only 2% subjects fell in the categories of severely stressed. Significant difference in the score of the PSS. There is no significant difference in the latency of comparing the 3 groups of students. There is no irrespective of their genders, and no significant correlation was seen between the PSS score with latency of GSR. The future researches include, the first point refer to, one of our major limitation is the sample size. We have to increase our sample size. Then second point refer to, subject has been included from the first year only. This need to be further extended to other semesters as well. Third point refer to factors that contribute to rising stress level of a medical student, and a similar assessment need to be done in other colleges as well, so that we can compare and generalize the result finding to pave the way for reform in the medical curriculum. It is the sum of the references that I use in my studies. Thank you. And ma'am, to find out the stress in medical student. Yes. No, it is done lot of time as well. It is, we found that there is an 63% of medical student was found in our college, 63. Yes, ma'am. Yes, because it is less mobile as compared to dominant hand. Less participant. Sir, participant does not like to move less dominant hand as compared to dominant hand. Electrode GSR reading will be hampered as well. That's why we use the non-dominant hand. GSR work on the principle of the electrical conduction, electrical conductance that is passed through the skin, that will pass through the skin by using the sweat. That is, we give the auditory stimulus that will lead to the emotional arousal level, that gave the autonomic system activate, that lead to sympathetic system activation and lead to sweat. that increase the conductance of the electrical confiable electric current. That is it.
You have used abbreviation in your title, GSR.
Yes, sir.
Should you use an abbreviation in your title?
Pardon, sir?
On your title,
Yes,
you have
sir.
used the word GSR.
Yes, sir.
Should you use an abbreviation in your title?
No, sir.
Then, have you done the review of literature on this particular subject? What was the lacuna in the literature?
Sir, I think so. These are the references that I use for.
The lacunae of the literature has to be mentioned beforehand, not at the end of the story.
Sir, I don't.
On the basis of lacunae, you do a research.
Yes, sir.
So I'm asking what was the research question based on lacunae. We have not mentioned the lacunae in the literature. So what is the idea of showing so many literature at the end?
Sir, to show, I have studied these studies to make my result compare with that.
That is one part.
Yes,
you
sir.
have to compare your result, you have to use in your discussion.
Yes.
At the same time, we have to mention in the very beginning, in the review of literature, you have to find out the lacunae. So that was lacking.
Okay, sir.
And have you got the ethical clearance? You didn't mention about ethical clearance.
Yes, sir. I mentioned it.
Well,
Ethical clearance. Here it is. Institutional ethical clearance was taken following approval by the SMA.
do they give any number?
Yes, sir.
Do they give any number for the ethical clearance?
Yes, sir.
What is the relationship between cortisol and stress?
Sir, increase in level of cortisol that will lead to the stress.
Have you known about the hypothalamo-adrenal axis?
Yes, sir.
So what is the cause of stress in medical students?
In an Indian medical student, there are various factors such as one of the reason may be the ragging as well.
Ragging nahi hai, Supreme Court has banned ragging, so you can't say ragging. I have complained against your college.
Okay, sir.
So don't say.
One of the reason may be the study, one of the failure of to cope up with the study, hard study as well as with.
Thank you.
One question, one last question. You have said that 63% were moderately stressed.
Yes, sir.
What is the criteria for classifying into mild, moderate, and severe stress?
Ma'am, PSS scale is used for criteria for classify them as moderately severe as well, or there are other DSR latency can also be used to crack.
So what exactly is the criteria in the PSS score?
PSS score, if the score is in between the 0 to 13, then it is in the mild, and then if there is in 14 to 26, then it will be moderate, and if there is in the up to 40, 27 to 40, it is severe.
So don't you think the title of the paper should be altered according to that, because you have done predominantly in the moderately stress?
Yes, ma'am. Yeah.
Thank you.
Thank you, ma'am.
Thank you, Dr. Rahul. Thank you, respected judges and other delegates and the audience for the kind listening. Now I request Dr. Shilpa Khullar, Associate Professor, ESIC Medical College and Hospital, to please come on the stage and felicitate the judges. Okay, okay. को उधर लेके आना है। डॉक्टर शिल्पी हियर, आपने बोला था ना जब फिनिश हो जाए तो आपको बुलाना है यहाँ पे। जी ओके, ठीक है ठीक है, ओके। हाँ मैम, शुश्रुत। अच्छा मैम कॉल कर लो, मुझे पता नहीं है। हाँ मैम आप कॉल करो, मैं रखती हूँ अभी। हाँ प्लीज़। हाँ तो पहले अनाउंसमेंट, फर्स्ट सेकंड थर्ड तीन। अच्छा so the results are ready. I request Dr. H.N. Malik and Dr. Divya to please come on the stage to announce the winner. Sir. हाँ जी sir.
So first of all, I would like to say,
बोल देता हूँ. We really appreciate your presentations and your taking interest in research. Yesterday we had a workshop how to stimulate young students to be involved in research from the very beginning. Young investigator workshop. Did you attend that one? No. नहीं किया attend. किया था? अच्छा. No. Yesterday we had one. And those, some people are having ICMR fellowship, that is also very good. So you should keep doing research. And very well done presentation, but we have only one award, so madam will announce the award.
thank you, sir. So first of all, a big round of applause for all the participants. You all did a very good job. It was very difficult for us to judge. So you all are winners. And keep it up. Keep up the spirit of research. It will, go a long way in your career. So, but we had to judge and we had to make someone a winner. So, the first prize or the winner of the Harish Gupta, the coveted Harish Gupta prize is, please put your hands together for Shivani Chaurasia, HIMS Barabank. Well done, congratulations. And at the second place, we have Rahul from ESI Medical College, Farita. Well done, thank you. दोनों आ जाइए स्टेज पे, सब लोग आ जाइए प्लीज.
Nothing to be disappointed. Please come.
Yes.
I have the last question also to four of you. Rupesh?
Arjun. Achha, Arjun is not.
Who was Harish Gupta? We have come for this award. We should know who was instituted. Who was Harish Gupta? He's no more. नहीं पता. तुम पहले पूछ लेना. All the best. Will you find out the answer?
Chairperson, I will just request you to stay back. I request Dr. Purvi Kulshresh, Associate Professor, Department of Physiology, AIMS Rishikesh, to please felicitate the judges. Dr. H.N. Malik. A big round of applause.
Honor for me too. बच्चे जब बड़े हो गए फिर अवार्ड दे रहे हैं हमें.
Dr. Divya Srivastava. Thank you, ma'am. Thank you, sir.
Thank you also. Very well anchored.
Thank you, sir. I now request everyone to kindly move to the Dhanvantri Hall for valedictory function. Thank you.